In 2010, we had invitations extended to Governor Walker and to the likely Democratic candidate Mary Burke. They declined those invitations. However, we do have, at lunchtime today, we will be addressed by two of the Attorney General candidates, so at least we got somebody who's running for statewide office to attend. We have a distinguished panel here. We have another one that will follow mid-morning. I will give you some invitations to the folks, or introductions, I should say, to the folks here. I want to thank them for attending and agreeing to be a part of this. This is very beneficial, I think, for all of us to get their perspectives. Just in terms of some housekeeping, restrooms, in case you didn't see the signs, they're located right out on either side of that registration counter where you picked up your speaker name tag. And then lunch, when it's lunchtime today, it will be served buffet style, so you'll get a plate right outside here in the hallway, and then you can bring it back in here and eat, and then we will hear from the Attorney General candidates. I'd like to get started just kind of with an overview, scheduled to give some opening remarks. And so what I've done is I've taken some of the slides I've used from presentations over the past couple of years, and just kind of as a background information to kind of set the stage for the panelists who will be speaking next. There's always a question as to why Wisconsin adopted managed care in the first place. And I think the reasons are very sound. In fact, the family care program is one of the most ambitious programs in the country. It essentially establishes an entitlement in counties where people have been taking off the waiting list. So the entitlement to long-term care is very unusual around the country, and Wisconsin really is at the forefront and has received a lot of national attention because of that. We know that one of the primary reasons managed care was moved to in the 2000s was that states like Wisconsin wanted to get more budget stability. In fact, they limit their financial risk essentially by passing part of it or all of it to contractors, to managed care organizations, which are paid on a per person per month basis. And that also allows the state Medicaid agency, the Department of Health Services, to hold those contractors, those managed care organizations, accountable for outcomes. So looking at employment outcomes or looking at some of the other community living outcomes, especially those that are being highlighted by the Centers for Medicare and Medicaid Services in their HCBS settings rule, the Department of Health Services is responsible to the federal government to assure those things are happening, but they then hold counties who are still in the legacy long-term care system as well as the managed care organizations accountable. So the things that they're being held accountable for are really making sure that it's the right service at the right time and in the right place, as well as making sure that the care that's provided or the services that are provided are good quality. In terms of some of the numbers of people enrolled in family care at this point, I don't know, and maybe Brian can tell us in a few moments whether or not this figure is accurate, but we've heard estimates that the state currently spends about $1.5 billion a year. There's about 49,000 people enrolled in long-term care currently in Wisconsin. And you can see some of the breakdown in the slide behind you. About almost 39,000 people were enrolled in MCOs as of January 1st of this year. The segment that is growing the fastest is the elderly segment. That's where we see the most people being added to the program. We see some slight increases in the developmental disability population, and it looks like there have been some increases in physical disabilities population as well. The one area that is also growing very rapidly is the IRIS program. That was a goal of this administration, to make sure that IRIS was put on a level playing field with other parts of the long-term care program. And in fact, there's over 10,000 people who are participating in IRIS currently. So as things have moved forward, one of the priorities for the Walker administration really was to make sure that the long-term care program was sustainable. And Nancy Thaler has been speaking about the need to look at sustainability for some time now over the last couple of years. And really looking at the types of services that are provided, you can see the most extensive service on that list is the intermediate care facilities for people with intellectual and developmental disabilities. In the federal lexicon, that's the ICFMR program. National average cost is roughly $128,000 a year. And if you start going down into less restrictive types of placements, you see that you can actually serve more people if you can make placements more integrated in the community. And in fact, if somebody lives with their own family, let's say, just in terms of comparison, you can see about 200 people could be served for the same amount of money as the 39 people in the ICFMR program. So it's made financial sense over time for Wisconsin really to take people out of those larger state-run or privately run ICFs and ensure that they had availability of community care. And that's part of why family care has been successful in driving down costs. DHS also, in 2012, as the result of feedback that they obtained in town hall meetings held in March of that year, established some long-term care sustainability plans, and these were reforms that the department was seeking that would help save money, but also make the program hopefully more responsive. The idea was to make it sustainable on an ongoing basis in the future, given demographic trends. The big demographic, obviously, is the potential for the baby boomers to do what's called the silver tsunami, which basically is to overwhelm the capacity of the Medicaid program to serve people. And so the other thing was to make sure that the program is kept consistent with the interests of current and future program participants. You can see some of the areas. In fact, all of this information is very transparent. They did a nice job of making sure that that information was available and all the goals were clearly laid out. So some of the areas, the main focus areas for the sustainability reforms included employment supports and family care, administrative and program efficiencies, family care benefits, IRIS and self-directed supports, living well at home and in the community, residential services, and youth in transition. Now, those of you, I know I've received some feedback from some of the members of the association that I direct, Rehabilitation for Wisconsin in Action, about some of the changes in the IRIS program. Well, those were clearly laid out in 2012. It wasn't a surprise to those of us who had read the sustainability plans that they were going to begin limiting the ability of IRIS participants to live in licensed homes. Big announcement was made by Governor Walker here in Green Bay about the expansion of the family care program for Northeast Wisconsin. And anytime you expand a program, there's opportunities that could be obtained. And we hope that some of the opportunities that are out there will be taken to make sure that this is a very smooth transition for everybody. I have looked at some of the things as other areas of the state have transitioned that could have been done differently, and I have a few suggestions. One of the areas I think that's important is that quality be a very key part of the implementation. And I know we have something called P&Es, and we also have external quality assurance organization reviews that are designed to help make sure that the family care program in particular is a quality service. There might be some other things that could be done to enhance the measurement of quality. So for example, there's something that we've brought to the attention of Wisconsin state government in the past, and we'd like to see them take a look at it again, and that is the YouSpeak Consumer Experience Survey. And that's just an example, but what's good about it is that it's an internet-based survey mechanism that allows you to compare different parts of the state to each other in terms of consumer experience, as well as different states to each other if on a common set of measures. It can be filled out very efficiently. It could be filled out in paper and pencil if it needed to be, and re-entered. But the idea there is that by getting baseline information about how things look now to those who are participating in the long-term care system, you will then also be able to see if things change over time. And we would hope that they would change for the better. Obviously, with waiting lists being addressed, we think that's a very positive change. And I know everybody in the 7-state area in which the initial expansion will take place is very thankful that that program is coming. Another area that I think is important, and I think we'll have some of our second panelists talk about this, is, just before that, I wanted to make sure that you saw some of the quality indicators. I've been doing some consulting out in the state of North Dakota with their Division of Developmental Disabilities. And some of the things that they look at in addition to the consumer experience are things like direct staff turnover in provider agencies. And they've established a baseline, and now they're going to move forward with the new rate setting system that has just been established there to see if it changes at all, and hopefully it would improve. The percentage of existing direct support staff that are appropriately certified, and they have some certification requirements, similar to some of those that we have here in Wisconsin. Percentage of individuals with intellectual and developmental disabilities who live in community settings of 4 or fewer. That was the goal of theirs. They didn't want to see people being placed in large congregate settings, and I'm not even sure that's going to be possible in the future given some of the CMS regulations that have been issued. Number and types of adverse events, and satisfaction that the needed supports are actually in the person's service plan. One other thing I think that needs to be looked at as contracts are being written with providers in this area is whether the assessments that are currently used for rate setting are adequate for that purpose. One of the things that we examined a couple years back was the use by one of the managed care organizations of the long-term care functional screen to actually establish provider rates. And we critiqued that at that time, and one of the things that we showed was that there were only really 12 items that were being used to try to set rates for somebody. So if you got one of those items wrong, it made a huge difference. Now, there are some cautions that should be associated with that. We know that the legislature a few years back actually went on record by saying that assessments, particularly the long-term care functional screen, should not be used to set rates. In North Dakota, one of the things that they did there was to establish the supports intensity scale as a measure for developmental disability services, because there are a lot more items that truly measure the support needs of the individual. I'm not saying that the state of Wisconsin might or should consider adopting that, but I just want to point out that when looking at using assessments for the purpose of rate setting, you have to have a lot of items to make sure you have validity. Another thing that I think would be important moving forward in this area would be educating stakeholders. Consumers and families have gotten used to the legacy waivers, KIP and COP, and even SDS, and one of the things that is going to be important is that they understand the new landscape as it relates to their ability to get services, and if they're unhappy, what they can do about it. In 2012, our association conducted some advocacy seminars and forums for over 600 people who really didn't know much about how the system worked or what they could do if they were dissatisfied with any part of it. And we think that something similar would be great if it could be fostered, helping people to learn the language of outcomes, working through disagreements with care management teams, and if necessary, following the appeals process. All those things really need to be addressed. One thing that might be useful for some of the MCOs, or the MCO that is going to be taking over this part of the state, is looking at different methods of provider payments. And as I said, I was working out in North Dakota with a company that actually has billions of dollars under their rate system right now. And what they do is they do what's called the BRIC method. The BRIC really is expressing all costs as a percentage of what you pay the direct service staff, which is great for workforce, and I know Todd will be addressing that later. We also would want to make sure that some of the information that we learned from Steve Schramm last year at the RFW conference as it relates to the capitation process, that there be some kind of a quality assurance check, making sure that all these steps have really been thoroughly examined. And he gave us this flow chart that you see behind us, which lays out all the steps that are involved in setting rates for the managed care organizations. Again, any one of those that's not quite right could make a huge impact on the ability of the MCO to provide services. And then there's, specialized services. And I know Kitty Rhodes has really addressed this with the competition that she has fostered in terms of having more than one MCO available for program consumers. And that is something that may come gradually to this part of the state, but it's being introduced in other parts of the state. And I think her hope was that there would be some specialized services available for people, so that maybe some of the MCOs would get really good at serving people who are aging, and others would get really good at serving people with intellectual and developmental disabilities or people with physical disabilities. And this chart shows you that their needs are really kind of different. When at bottom line, a person with an intellectual and developmental disability has a need for lifelong support, whereas typically the person who's aging is going to have a shorter time during which they're going to be supported. And the person with the disabilities oftentimes needs assistance in directing their care, whereas the elderly person, if they don't have Alzheimer's, can often participate in directing their care. And in regard to people with intellectual and developmental disabilities, supports really should be based on normalization and active treatment concepts. I don't think those have gone out the window, but I think people kind of forget what those are over time because other considerations come to the fore. Whereas really the care for the older aging people who need supports are really, that care is directed to making sure that they stay out of nursing homes, stay out of the hospital, et cetera. So different aims and objectives, and so it would be helpful if services were specialized, in my opinion. So with that, I want to give a little bit of information about our distinguished panel here. Representative Mike Ensley is on the end, coincidentally. Before being selected to serve the 26th Assembly District in the State Assembly representing the Sheboygan area, he worked in the private sector for 26 years. He held various sales management positions for Wisconsin-based companies such as Stolting, Polarware, Pemco, and Thomas Products, no relation to me. Mike currently serves as the chair of the Assembly Committee on Aging and Long-Term Care and is the vice chair of the Assembly Committee on Small Business Development. He also serves on a number of other Assembly committees. He graduated from UW-Platteville in 1984 with a double bachelor's in psychology and business administration, along with a minor in sales training and personnel. Janet Estervig is here in the middle. Janet is the section chief for employment initiatives at the Department of Health Services. She was actually the executive director of Work Opportunity in Rural Communities from 1983 to 2008. WORC provided individuals with support for employment, and as the executive director of WORC, she also provided best practices training throughout Wisconsin, nationally, and the United Kingdom on supported employment, vocational assessments, staff training, and nonprofit management. Following the work she did with WORC, Janet was the director of personal care services for Community Living Alliance, which Todd directs, which had over 800 personal care workers and has a mission of helping people remain in their homes as independently as possible with self-direction for their care. And last but not least, Brian Shoop. Shope or Shoop?
You're close.
Okay. He will correct me. Was appointed as administrator for the Division of Long-Term Care effective May 20th of last year. He came from Brown County right here in Green Bay as the Human Services Director, where he was responsible for the oversight of a very large public agency providing psychiatric inpatient, intermediate skilled care, and a continuum of other long-term care services. Prior to serving in Brown County, Brian was the chief of operations of the Seven Seas Counseling Clinic in Marquette University, which is a teaching clinic for teaching master's and doctoral students in the integrated treatment of co-occurring psychological and substance abuse disorders for youth, adults and individuals with disabilities. And he was responsible for the day-to-day operations of the clinic and a branch clinic. He also served as the executive director of Ministry Behavioral Health, a part of the Ministry healthcare system, in addition to having led several other nonprofit organizations. Brian holds a Master of Public Services Administration from the University of Wisconsin at Oshkosh and a Bachelor of Arts in Sociology from Lakeland College. With that, who would like to go first? Mike? A round of applause for Mike Ensley.
Never start out with a negative comment, but I have to be honest. As of this morning, my glasses have been run over and are laying in my garage under my car. So please bear with me as I attempt to try to follow my notes. First of all, just good morning. It's an honor to be here as one of your featured speakers for the 2014 Aging and Disability Policy Forum. I really appreciate the opportunity to come here and to not only listen, but to learn. As mentioned, Mike Ensley is my name. I'm the state representative for the 26th Assembly District, which encompasses, for the most part, all of Sheboygan County. I do serve as the chairman of the Assembly Committee on Aging and Long-Term Care. I also am the vice chair of the Small Business Development Committee, and then I'm also a member of the following committees: Transportation, Veterans, Children and Families, and Tourism, as well as a member of the Transportation Projects Commission. As the chair of the Assembly Committee on Aging and Long-Term Care, it has been a true privilege to be directly involved in legislative initiatives that have come before us. Today I've been asked to share a few of my perspectives on some of the recent successes relating to aging, long-term care, and initiatives that support employment opportunities with people for disabilities. As I'm sure you all know, Governor Walker's State of the State speech unveiled his Blueprint for Prosperity plan. As a part of that initiative, the governor also proclaimed 2014 as the year of a better bottom line, employment opportunities for people with disabilities. The governor's proclamation directed state agencies to encourage, promote, and recognize programs that assist with the integration of persons with disabilities into Wisconsin's workforce. Shortly after that, the governor unveiled the Blueprint for Prosperity plan. The Wisconsin State Legislature then passed important legislation such as Special Session Assembly Bill 2, which I was proud to support. Special Session Assembly Bill 2 expanded the Wisconsin Fast Forward program and required the Department of Workforce Development to use appropriated funds to provide grants aimed at enhancing employment opportunities specifically for people with disabilities. It is important to note that the provisions of this bill that relate to increasing these employment opportunities for people with disabilities will help expand the successful Project Search program. This program is a business-led collaboration that gives young adults with disabilities the ability to take part in a 9 to 12-month program that provides them with training opportunities as well as future career exploration. This program is maintained through a strong partnership with local businesses, area schools, the Department of Workforce Development's Division of Vocational Rehabilitation, and a disability service organization such as a managed care organization. As we work to make Wisconsin's workforce stronger, employers have an opportunity to gain tremendous value by hiring individuals with disabilities. I also believe the governor's proclamation shines a very important light on the Wisconsin organizations that are already dedicated to helping empower people with disabilities. By working collaboratively in this way, we can help these individuals make a smooth transition into the workforce. These organizations and Wisconsin's vocational rehabilitation program are important for not only the program participants and their families, but also for the businesses that engage in these programs who gain hardworking, wonderful employees. In addition to the important work done during the year of a better bottom line, as well as the governor's Blueprint for Prosperity, earlier this year, Wisconsin also saw the introduction of the Department of Health Services Dementia System Redesign. Again, in my capacity as the chair of the Assembly Committee on Aging and Long-Term Care, I was fortunate to take part in a Dementia Care Stakeholders Summit that was held last October. This summit was brought together 33 different stakeholders with various perspectives in order to identify areas where the department can work in conjunction with their partners to simply make Wisconsin more dementia capable. In Wisconsin, it is estimated that 110,000 people are affected by Alzheimer's. Across the nation, that number climbs to more than 5.4 million. These staggering statistics demonstrate a growing need for innovative ideas on how to make our state more dementia capable. Following the release of the summit's results, Department of Health Services Secretary Kitty Rhodes has led the department's dementia care system redesign process to ensure Wisconsin is providing both appropriate, safe, and cost-effective care for the people throughout the course of Alzheimer's disease and related dementias. Over the two-day summit, key stakeholders discussed key features of what Wisconsin's dementia-capable system may look like, potential strategies for achieving a more dementia-capable system of care, and concrete strategies on how to achieve a more dementia-capable system of care. As a legislator, I found this fascinating to hear the innovative ideas that many of the Wisconsin counties have pursued on their own in the last many months, and if not years, in an effort to adapt to the growing needs of their aging populations. These presentations were referred to as bright spots and provided basically a starting point for the discussion of potential supports and services that will be needed in various areas of Wisconsin's dementia system. At the end of the summit, this collected effort helped develop the Department of Health Services plan for a dementia-capable system of care. Available for review, the report outlines efforts to help address gaps in the current care system, which can be addressed, and community crisis services that can be expanded to appropriately serve people with dementia-related diseases. I know that Brian Shoup will go into further detail about this plan, its approach to updating Wisconsin's dementia plan. However, I would like to add again that I consider myself very fortunate to have spent the initial 2 days at the stakeholders meeting. It was very, very interesting, and I was proud to see the passion that the people had at that meeting and the ideas that they had. Before I wrap up my portion of this forum, I would also like to add that I was proud to join Governor Walker earlier this month, matter of fact, right here in Green Bay, when the governor signed Assembly Bill 710 into law. Assembly Bill 710 is commonly referred to as the Silver Alert Bill. This legislation was referred to the Assembly Committee on Aging and Long-Term Care, and I felt privileged to serve as the chair on a committee as members heard testimony from a number of people on a number of different issues involving this type of legislation. The Silver Alert system simply has the potential to save lives for adults at risk. Assembly Bill 710 defines adult at risk as an individual who is an adult and who has developmental disabilities, who suffers from Alzheimer's disease or other dementias, or suffers from or could suffer from without access to medication. According to the Alzheimer's Association, more than 60% of those with Alzheimer's or another form of dementia will in fact wander. And if a person isn't found within 24 hours, about half of those individuals who wander will suffer serious injury or death. This tragic statistic shows why it was necessary to pass Assembly Bill 710, so that we can ensure the timely recovery of an adult at risk that may be in danger of getting lost, especially considering the bitter cold elements that we deal with here in Wisconsin. Once again, I want to thank you for the chance to be here. I truly believe all of the legislative initiatives I've spoken about are very important to Wisconsin citizens as well as our aging population. Again, it has been a privilege to be involved in these policy decisions, and I find myself fortunate that I had a chance to chair the Assembly Committee of Aging and Long-Term Care. Over the last legislative session, I have not taken the legislative initiatives within the purview of our committee lightly, and I'm glad we could pass meaningful legislation that in fact will protect our most vulnerable citizens. I'd be happy to answer your questions following the speeches of the other speakers today, but I also do want to say to all of you here, thank you for what you do. I have spent in the last year and a half a lot of time visiting a lot of the different facilities, and it's heartwarming to see the kind of compassion and passion that I saw in all the places I went to. So I'd just like to say thank you for everything that you do. Thanks.
Good morning, everyone. I really appreciate the invitation to come here and tell you about some of our initiatives. We'll talk a little bit about employment, too. And some of the heavy lifting on that will be done following me by Janet. It's always good to be back here in Green Bay, where I spent almost 4 years, and it's allowed me to reconnect with some of the familiar faces, Mike Duchesne, John Bloor, who escaped to Milwaukee, or West Bend, I believe it is. We had a chance to talk earlier, and I see Steve McCarthy sitting there. I didn't have a chance to talk with you. Hope we can connect. So we were blessed in Brown County with some strong agencies, and I certainly want to tell you how much I appreciate the work that all of you are doing. Just a word about Representative Emsley. I told him this morning before we started that I was really sad to see him stepping down. He mentioned the summit meeting that we had on dementia that Secretary Kitty Rhodes had actually tasked me with when I started. And I really appreciate the fact that someone as busy as a member of our state assembly would take 2 full days, not including the travel time, to go down to Racine and spend in this summit meeting on dementia. And thanks again, Mike, for doing that. I really appreciate that. Actually, that was the connection that I had with Secretary Rhodes a little over a year ago. There was a special legislative study that had been held on dementia following the court decision, Supreme Court, U.S. Supreme Court decision, Helen E.F., if some of you are familiar with that. And Helen E.F. Was a person with dementia who had been admitted to a psychiatric hospital. And as a result, there was a lawsuit filed. It worked its way up through the appellate courts into the U.S. Supreme Court, Wisconsin Supreme Court, I misspoke. And the Wisconsin Supreme Court ruled that a person with dementia who has no other comorbid mental illness cannot be placed in a psychiatric hospital. That was a significant landmark decision and really precipitated a sea change in dementia care, or at least, at the very least, emergency treatment of people with dementia when they go into crisis. I had read her testimony that Secretary Rhodes made to that Special Ed Council, and where she spoke about the Department of Health Services needs to fix this. She said, task me with this, and we will take care of this. As Executive Director of Brown County Human Services, we were one of the larger public agencies, and when the Secretary talks about making sweeping changes, we listen to that, and we want to have more information because we know we're going to be affected. So I had not really met her before, and I called up, requested a meeting with her, and we started talking. We had a follow-up meeting, and we got into family care. I had been involved, of course, in the planning of the 7-county region here in terms of family care expansion, and I was curious as to what she could tell me about where we were at. Her response was, how'd you like to be part of the bigger picture? Now, I didn't know what she meant when she said that. So she had to spell that out for me. And I smiled. I said, actually, I was planning on retiring at the end of this year. She said, well, you can scrap those plans. Those of you who have met her know what I mean. I asked if I could have some time to think about it. She said, sure, take a week. If you need 2 weeks, take that. But the answer is going to be yes. So I've never had a job before where I was commanded to take it, but I found out. Now, I will tell you that that's how she leads. So one of the things I asked her was, what are the deliverables? What do you want to do with the long-term care division? She said, first of all, Wisconsin is going to be known as the leader. Now, she didn't say a leader, she said the leader. I took that to mean number one in the country. Secondly, she said, we need to redesign the whole system of dementia care, as Representative Inslee referred to. Thirdly, she said, we need to integrate behavioral health into long-term care. We should have done that from the start. We didn't, so we need to do it now. What that means, I want to be real precise about this. It doesn't mean that long-term care is going to be responsible for all of behavioral health care in the state. But what she meant was, for the people that receive long-term care, we need to have our own, we need to develop our own organic capability throughout the state. When those folks have behavioral health issues, we need to be able to deal with that in a holistic way as we provide their long-term care services. She had a number of things she called her bucket list that were handed to me, but another key one was in the area of employment. Secretary Rhodes, if you've met her, you'll know she's no wild-eyed idealist. She's highly realistic. But when she has a goal, she sets the bar as high as she can. She believes that everyone in long-term care between the age of 18 and retirement age should be included in the workforce. And when she says everyone, she doesn't mean some. She doesn't mean most. Her goal is everyone. Will we achieve every single one? No, but that's how she sets the bar. We're expected to try. We're expected to work hard at that. We're expected to do our best chasing that goal. More about that in a minute. Representative Inslee referred to the expansion of family care, as did Thomas in his opening remarks. We're very pleased that the governor and the Joint Committee on Finance have seen eye to eye and seen the need to expand family care into these 7 counties in northeast Wisconsin. We're very happy. We were tasked, as you know, by the legislature after the biennium budget process last year to deliver a report on managed care, actually, specifically family care. And we delivered that in December. If you've seen the report, and it's available on our website, and if you don't want to read the whole thick document, you can read the executive summary, about 3 pages, and I think you'll get the gist of it. What we reported was we made the following conclusions: that by expanding the rest of the state into family care, we will save $34.7 million against future growth, and at the same time be able to get 1,600 individuals off the wait list in the remaining legacy counties. several times I was asked, why didn't you make a recommendation? Why did you stop there with those conclusions? Why didn't you make a recommendation? Well, the answer is we weren't asked to make a recommendation, and we wanted to hold true to what we were tasked with by the legislature. So we were very pleased that the governor and the local delegation of the state legislature announced here in Green Bay, I think it was a week before last, that the expansion was going to go forward. We see that as a positive move, and we look forward to starting the procurement process. The governor indicated he wanted this done on a fast track, which meant specifically, as he said, in 4 weeks, I would like to see, 4 to 6 weeks, I would like to see an RFP out there. We're going to do that. We're going to achieve that. And I hope, my own goal is that sometime in the early part of next year, we can begin enrollment and getting people off the wait lists in the 7 counties that are in legacy waiver here in northeast Wisconsin. So we're excited about that, and we hope that eventually we hope to get all remaining 15 counties into the family care model. Let me say a few things about family care, capitation, managed care, and how family care was designed, how it works, because I think that's important for all of you who may be part of the provider network. And some of you, I know, already are network providers in some of the downstate, balance of state counties that are already in family care. You need to understand that all of the MCOs are capitated. And what that means is they are at risk on a per member per month basis. They are free, and this was how the system was designed, they are free to meet the deliverables that we require of them in our contract with the MCOs. They are free to negotiate rates, conditions, etc., as long as they meet the terms of the contract. Periodically, I speak to a lot of provider groups, and I often get asked, why does the department not specify rates? The reason why we don't specify rates is because that would defeat one of the pillars, one of the foundations of having capitation, of having the family care system designed. Thomas already, I think, did a good job laying out some of that foundation and the reasons why. But one of the things that I always want to get across to providers is just as the MCOs are free to have great flexibility in how they structure the contract, what they pay, so are providers free in terms of what they propose. One of the things that I also say is that working under capitation and working under a managed care environment requires you to rethink your business models. I came from the field of behavioral health. One organization that I ran for 20 years, I was there during the transition in general health care into managed care environments. We had to change our business model. I found that if I only focused on rates and only focused on the needs of my organization, I missed the point. Thinking beyond that, thinking of new business models enabled us to frankly thrive. But we had to change that business model. We had to change how we were thinking. And, I look forward to continue discussion about that. I say the same thing to MCOs when I meet with them. They need to rethink this. I'm chewing up quite a bit of time. Let me touch on employment. As we all know, CMS has published its final rule, and with respect to the community and home waiver. And with respect to employment, it's very clear what they have published. They're going the direction of integrated employment for persons with disabilities. Our secretary has gone on record many times indicating that she sees a need for a compendium of services in employment. And what she means by that compendium is that she is fully supportive of integrated employment. That's the goal, that's where she would like things to go. But she also recognizes that facility-based employment can be an integral part of this goal, and particularly understands that persons who have been in facility-based employment for many years, sometimes decades, that it would not serve their needs to simply say, let's close these facilities, or we're no longer going to use Medicaid dollars to fund them. That's not where we're going. But what we do need is a partnership with those of you who are working in this area. And we welcome that partnership. We have some ideas, but more than that, we'd like to hear some of your ideas as to how we can reach this goal, and how, if CMS in its ultimate interpretation that we're all waiting for, how we can redeploy, in some cases, change some business models, or adapt the concept of facility-based employment to serve those greater goals. And Janet is going to be talking about some of the thoughts that we have on that, and we're frankly, we're meeting with the board of RFW, I believe, at 1 o'clock, and we're looking forward to a good, solid, honest conversation about this. We see you folks as our partners to accomplish this. So with that, I'll just turn it over to Janet. Thank you very much.
Hi, I'm Janet Estervig, and I know a lot of you out there. I've been doing trainings for a lot of your programs and agencies and facilities on how to do supported employment. How do you find jobs for people? And in the end, I think this is what Brian was saying, we do look at the message needs to be quite clear that you are the people providing those services. If you're in integrated employment, or if in your facility-based employment, or even day services, all of them are looking at how we can connect to businesses in the community, and you're placing people in jobs. So in the end, we know that this is the provider network that we're interested in expanding and growing, because we know integrated employment is where we're going to be growing as we move forward. Like we say, we don't know what CMS is saying. We know some of what they're saying, right? Some of you have read of that. And we know that the final interpretation of the rule is supposed to be coming out this summer. So once that's out, we'll definitely have opportunities to get together again. So what my role is as the manager or section chief of employment initiatives at Wisconsin, I just started this in July. I have been a provider of services for 30 years, so I understand what it takes to train staff, have turnover in staff, how to connect to businesses, how to make these jobs happen for people, how to support people in jobs, how to provide the personal care services to get the people to the jobs. So I think, I come from this perspective, and I hope that that's going to be a real value. And I think that they hired somebody in the state service for that purpose, because I have that practical knowledge of what it takes to make this happen. So hopefully I am going to be here to help provide support and meet with you and figure out how we're going to do this together as we develop the Wisconsin 5-year transition plan they talk about in that CMS rules. But right now, there is a lot happening, and I think one of the biggest focuses that's happening, our Secretary of Rhodes really does like to see employment. And so she says, how can we make employment grow? How are we going to do this? So we talked about this, and she's been focusing on youth. And so we've got a lot of programs happening right now for youth. There's the Promise Grant, which some of you might be familiar with. They're going to need providers to help provide work experiences and job placement for young people, 14 to 16-year-old, who are on SSI. So that's all disability groups. And so that group of kids are going to be getting this intense support from DVR case managers that are designated promise counselors for that purpose. And they're going to be working with these kids, but also their families. This grant is really quite exciting because what it's going to do is be able to look at the wrap around the family. So what can the family do? Are there people with their parents or siblings in the home that could also qualify for services with the Division of Voc Rehab? Are there things that they need for housing? What are the is education and training needed? So it's really going to be looking at wrapping around that whole family. And the ideal is, of course, helping them move into not having to be any longer on SSI. So it's a pretty exciting opportunity. There's going to be 2,000 kids brought into the program, but because it's a demonstration grant, only 1,000 of those youth will be actually receiving services. The other 1,000 will be the control group. But 1,000 people, families and students in Wisconsin need providers. So we're going to be needing work experiences and job placements for these students. So there's a website, promisewi.com. Definitely go there. There's a lot of information on that website. And a lot of the website also is geared to younger people. It's flashing pictures and ways to really connect to the youth. So there's a lot going on there. And then, as we talked about, the governor's initiative, his proclamation on the blueprint for prosperity, he's really highlighting employers that are hiring people with disabilities every month. He's really been focused on, even in a State of the State address, on highlighting employers and people with disabilities as capable and able to be employees and contribute to that business. And when he talks about the better bottom line, he's saying businesses are better off by hiring people with disabilities. And any of you who have done this, right, who've done job placement, you know that. You know that. Employers embrace people with disabilities, and the people that are working there gain so much from that, not just the person with a disability, but the coworkers as well. So it is a better bottom line. We know this. So then the governor also talked about the expansion of Project Search. And so right now there's 7 sites in Project Search, and there's going to be another 20. We got to do this in 3 years, so it's going to be a lot of work. But it's funded through the DWD, Department of Workforce Development, but it's coming directly to Department of Health Services, DHS, because we manage the Project Search. We have the Project Search statewide coordinator. And so we're going to put a lot of time in getting these new sites set up. We have a request for applications out. I don't know if any of you have been interested in talking to the school districts, VR, and then we need providers that are partners in creating, and then a business is usually at some point brought in too, doesn't have to be for the RFA, and get this information. Please apply to this because we really want to start up with 7 new sites. And then next year there'll be 7 more or more, and then the next year 6. That gets to our 20. But we really have a lot to do. And what it is, it's a full immersion program. Basically, you have a business that has a classroom, a teacher in the business, not at the school, and the students have rotation sites throughout the business. They have an opportunity to get work experiences throughout the year, and this is part of their last year of school. And then the placement rates are over 80% of those students when they graduate from Project Search. So it is an amazing program, but as you could just think about it, if you have full immersion in understanding what it takes to have a job and getting work skills in hospital settings or other larger business settings, of course, doesn't it make sense that you would really have that good work experience to leave and then get jobs, either jobs at the host businesses, but most of them get jobs in businesses in their area. So we have a lot of work to get those all started. There's been other smaller grants that's been happening with school districts, like Let's Get to Work grants, those of you who might be involved in those school districts. Really, again, focusing on getting youth work experiences early while they're in school, having them get jobs before they leave the school or right after they're done with. So it basically brings the students directly into integrated employment. So there's also a lot of work being done, again, at that youth with the Children's Long-Term Care Services coordinators. And this is children's services, so these things might be people you might work with them, right? So the children's coordinators are really looking at how they can have conversations with families and with students and youth about employment and jobs, and having those conversations early. We even talked about birth to 3. Yeah, because if you see somebody with Down syndrome bringing in your tray in the hospital, you see and you've just had a Down syndrome child, and you say, wow, there's something for my child. Look at, they're working, they have a job. And it changes expectations of parents, and this is what we want to see. And so we're looking at the whole spectrum, and then we get to the adult services. So how are we able to now in the adult world look at having a vision of employment for people and believing that they can work. So it's not just, first of all, it has to be the person with a disability and their family. They have to believe they can work, right? They have to have the idea that, yes, I can have a job. Then you've got to have employers and businesses who say, hey, I want to hire people. I need a labor force. I'm desperately needing a labor force. And I'm looking for someone who's going to be reliable. I'm looking for someone who's going to be honest. I'm looking for someone who's going to show up every day and do this job and have the attitude that they really want to work. That's what I want. I'm looking for. I can teach the tasks that have to be done. And then we need providers that have the skill sets, and all of you have worked very hard to develop these skill sets on how to make this work. How do I talk to businesses? How do I train people in a job in the community? How do I connect my provider agency with the business community? How do I talk the business talk, right? So those are the things that we got to have that all matched together. And then we got to have the funders, the MCOs, providing the funding to make this all happen. That could be another thing, right? We could talk about that for a long time. Well, I'm actually in the Office of Family Care. I'm in the Office of Family Care expansion, is what they actually call the off-key, we call it. And so in that, I've been able to have, and I've only been there since July. I'm a 10-monther for the state service, but I've learned so much about how managed care works, and I've known about family care, but now I'm on the inside, and it's very interesting because I just find, and this is honest, there's such committed people to try to make all this work in the state of Wisconsin, and on very few staff. It's amazing what they do for so few people, and they really want to deal with the quality of the services. They want they hold MCOs accountable. This year, for the first time, the MCOs were required to put, how are you going to grow integrated employment in their business plans? So every MCO had to come up with ideas of what they were going to do as an MCO on how they were going to help the business integrated employment grow. So it is really about, you can see it's kind of like the stars are all aligned. We've got the governor's office who's very excited about this and helping to open doors with corporations. We have providers and we have people with disabilities saying, yes, let's figure out how to make this all work. And so at the state, at DHS, our job is to try to help bring this all together and to figure out how we can use those funds, the funds that are being paid for integrated or facility-based employment. How can we bring all those funds together to really make this all happen for people? There's also a big push, too, for work incentive benefits counseling. Again, people think, well, I can't work. I'll lose my benefits. And so there's a lot of fear in that, and there are so many possibilities. So the work incentive benefits counselors are really growing. They've become a well-trained group of people. Wisconsin's put a lot of time and effort and funds to really train the benefits counselors so that they know exactly what they're doing when they're talking to people with disabilities and their families. And so there's a lot of resources out there. DVR has made a commitment to pay for those services. The Promise students will all have a work incentive benefits counseling counselor that will work with them in developing a plan. And the MCOs have the ability to pay for those. It's in their list of services, right, for being able to provide work incentive benefits counseling. I truly think that that has such a benefit for families and people with disabilities to really see what is it that I can do. Can I work? Maybe I can work part-time. I still need my personal care worker. How can I still have my personal care worker and be able to work? It does happen, and it can happen. So if any of you are benefits counselors out there, you know, there we go. I saw someone smiling, so I thought maybe we really want to promote that. And so we've been working hard with, we have a campaign that we're doing right now, too, for people with physical disabilities. People with physical disabilities are some of the lowest numbers of people working in the community. And we say, why? Why? The skills, people have college degrees, master's degrees. Why is that? So we have to figure out how we can support that. So we're developing this campaign, and it really is just an awareness. Go and talk to your benefits counselor if you want to work, or we think you can work, or even if you don't think you can work. Go and talk to them, because we want to really promote that idea for people. So we have this campaign we're developing to really focus on people with physical disabilities, on how can we get that message out. Yes, you can work, and talk to a benefits counselor to find out how you do that. So as we kind of continue down this road, we know that family care, the managed care organizations, IRIS, have, and then the legacy waiver counties, there's 3 groups of people that are working on employment. So every month, we're meeting together as a group. Your employment coordinators from the MCOs, we meet with the IRIS employment coordinators, and then the Legacy County, we include them in as well because they're doing a lot of employment work. And we talk about what are some best practices, what can we look at, how can we promote provider capacity and build provider capacity for integrated employment. How do we make this happen? And so we as a group talk, and I think that, again, the next step is let's talk with all the providers. We want to have conversations with you as well. Those have been very valuable, and that's been going on for a while. We did talk about some of the business models, and I have experience just in some ideas of that, and I want to be able to have a chance to share some of that with all of you. Check the time. To share that with all of you, ideas of how are there incubator businesses? Are there integrated businesses? Are there things that we can do in enclaves or group work sites that we can really bring people together to be able to do jobs and grow jobs for people in innovative ways, because we know we still have to be cost efficient, as you all know. We have to figure out how we're going to be able to provide supports for people in jobs. How do we do really good job matches to do that? So we really want to talk about sort of how do we provide those supports, and how do we give opportunities for people who are friends to still see each other if they're working in the community. These are things that for 25 years as a provider, I always had in my mind. How do we help people stay connected? How do we help people be able to see each other that are friends? How do we find jobs that really good matching so it doesn't require so much job coaching? How do we get good skilled job coaches out there that understand what fading is, understands how to help people integrate into their work environment? How do we do all this, and how do we approach businesses and hiring? So I'm hoping that we can do some more. If there's some training opportunities we can think about and work with the provider network as well. So just looking at what kind of business development opportunities there might be. IRIS has been fun. We've been having a chance to talk about how on self-directed service employment supports. That's been interesting because we've been talking about either provider supports, but also how could you manage your own budget and figure out how to support yourself if you have a disability for a job or an employment. And there's a lot of possibilities in that area as well. And so again, this is what we hope to have the conversation about and continue to talk about. Obviously, I'm very excited about this because I get really excited and get really loud when I talk about employment for people with disabilities, because I really have a belief in this. And so I think the message I can say is that DHS is committed to this. DHS wants to look at how we can support integrated employment, but support you as well, and how we can make this work with our full array of services that our secretary talks about and is supportive of, and how can we make all this fit together with the expectation that we are going to grow in integrated employment. In the end, that's what CMS is asking us to do. We don't know exactly what they're going to say in the final rule, but we do know it's still talking about where are the settings that people are getting these services, and we know that it's going to be community-based, so we're going to work hard on that. All right, thank you.
Thanks to our distinguished panel for their discussion of what's happening in long-term care currently. We have some time for questions. I think there's about 10 minutes. There is a wireless mic that our videographer, Mark, is holding there. So we ask that if you have a question that you speak into the mic, because we are recording the session for distribution and airing on YouTube to extend the awareness and learning here. So with that, we'd ask that if people can, if they can come up to the podium to answer the questions as well. So there may be a little delay as we get questions and answers.
This is for Brian.
It won't be on the loudspeaker.
Could you be a little more specific about the timing of where we are with the expansion for northeastern Wisconsin? Relative to does joint finance have to give a blessing here? You kind of said beginning of next year. Could you be more specific?
Yeah, that's a good question. The question was, what are the specifics in terms of a timetable for expansion of family care here in the 7 counties of northeast Wisconsin? And I appreciate that question. Let me tell you a little bit about the process. The second question you had was, is there any further blessing that has to occur to make that happen? The short answer to the second part of the question is yes, and I'll take you through the process. The first thing that we have to do is issue an RFP, and as you recall, I indicated that the governor in his announcement here in Green Bay indicated that he wanted that RFP, the request for proposals, published within 4 to 6 weeks. We will accomplish that. So that brings us somewhere around late May. We haven't nailed down a specific date in late May, but that's when you'll see it rolled out. We will then obviously have approximately a 2-month period to receive proposals, 2 to 3 months, and understand that these proposals can come from any viable organization, although we expect that they will likely come from existing MCOs. After that, we will obviously begin the process of selection. There will be a team that will be appointed to consider the proposals. Under state procurement rules, that means a firewall will come down. I will not be on that selection panel. I will not even know who is on the selection panel. It will involve some of my team, and I will not know who they are. When they make their decision, then that would be announced. We would begin a process that is in simple words, the process of negotiating a contract with that MCO, or if we choose to select multiple MCOs with those MCOs that were selected. Once we develop a draft contract, we would then take that to the Joint Committee on Finance, which, as you may know, this procedure now requires, as of I think 2011, now requires an active review by the Committee on Joint Finance. And that means that they have the last word. They can approve it, they can disapprove it. At that point, at this point, the internal mile markers, I really hesitate to give you. We have to work those out. But I would like a stretch goal of beginning enrollment somewhere in earlier part of 2015. In fact, the To be more specific about that, what I told my leadership team was somewhere before the end of the first quarter. They kind of winced, but we're going to see what we can do. We don't want to waste a lot of time. We're taking a cue from the governor, and there are people who have been awaiting care for a long time on those wait lists, and we feel that we have a duty to act on that. Thomas did a good job of talking about entitlement. Let me add something to his words of entitlement, by the way. He said family care brings entitlement to a variety of services. It does. Consider that currently in these 7 counties, and in all of the counties prior to the advent of family care, there has always been an entitlement. But that entitlement has been to institutional-based care. And that's the difference. That's what family care brings. That's the difference maker. And that's why we're excited about family care expansion. Thank you.
It's for Brian. You can stay there. Last fall, a number of us met with Secretary Rhodes in Eau Claire, and she indicated that there was going to be a revision of the functional screen that would expand what was measured in that screen. Can you tell us the status of that?
Yeah, thanks for asking that question, too. You recall that one of the things that I indicated that Kitty had in her bucket list, one of the buckets was integrate behavioral health care into long-term care. And the functional screen is a key part of that. Right before I started, Kitty asked that the functional screen be revised to pick up with greater sensitivity any behavioral issues that need to be addressed in the area of planning of services, eligibility, for the person's choice. And so what has happened is that there is an instrument that we're calling provisionally a behavioral health supplement to the screen, to the existing functional screen. And we've had a team working on that. It has now gone through a pilot testing phase, and it is well, let me just say it had gone to being programmed. So because all this will be used with online. I've had a meeting with some of my team about it this past week, and I asked that we pause for a few days because I had some concerns that I need to have addressed. And one of those concerns is how we train trainers specifically in the area of behavioral health. That's been my field. I'm not a clinician, but I've hired a whole lot of clinicians in my career. And I was concerned about how well we're training and do we have the right people doing the training for ADRC staff, for MCO staff, many of whom have never had a background in behavioral health. So we're going to pause for a few days. I don't believe this is going to seriously delay the implementation. We were shooting for sometime end of July. If it goes to the 1st of August, I'm perfectly happy with that because this is an opportunity that won't come around again for some time, and I want to make sure we're getting it right. But thank you for that question.
Just kind of a follow-up on the RFP process. The Lakeland Care District MCO is presently in an RFP renewal, and
Yes.
the cow counties, Calumet, Outagamie, Wapaka.
I'm sorry.
Calumet, Outagamie, and Wapaka
Yes.
are also. Where is that process at in relationship to their renewal or non-renewal or
Well, let me just
combination?
give Katie Monk, who happens to be here, who's the CEO, a chance to make a comment if she would like.
Sure. Those proposals, requests for proposal responses are due May 16th to the Department of Health Services.
Katie, of course, is the incumbent MCO. Thank you.
Next group of panelists, if I can have your attention. First, I want to start with the gentleman on the far end over here. He's not on the far left normally, but no. Forbes McIntosh is the president of Government Policy Solutions. For nearly 20 years, he's had experience providing full service representation for clients at the state, municipal, and county levels of government. Today, he's speaking on behalf of the Residential Services Association. Forbes is really well respected for his knowledge of the legislative process and his methods of lobbying by both Democrats and Republicans in the Senate and the Assembly. Prior to founding Government Policy Solutions, he worked with the lobbying firm of Broidrick and Associates and received his Bachelor of Science degree from the School of Public and Environmental Affairs at Indiana University. In the middle there on the panel is Todd Costello, who is the Executive Director of the Community Living Alliance. Community Living Alliance is a community-based nonprofit organization in Dane County. They provide services and community resources for all people with disabilities and chronic illnesses and for older adults. CLA was founded by people with disabilities, healthcare professionals, and concerned citizens. Their history spans 2 decades and is firmly rooted in the support for values of the independent living philosophy. Todd is representing the Wisconsin Long-Term Workforce Alliance, where he is the chairperson. And then finally, last but not least, we have Janet Zander, who is the Advocacy and Public Policy Coordinator at the Greater Wisconsin Agency on Aging Resources. And in her current role, she coordinates the advocacy and public policy objectives of GWAR and is working with within a 70-county and 11-tribe planning and service area. She's devoted to building greater grassroots and key contacts capacity and fostering appropriate relations with elected officials. As the director of the Portage County ADRC from 1997 to 2013, she was also responsible for the oversight of the Department of County Government that's responsible for the delivery of the Older Americans Act and Senior Corps programs and Aging and Disability Resource Center contract services to the citizens of that county. So we have people who are well-versed in long-term care issues, and I will ask Forbes if he would not mind going first.
Well, good morning. As Tom said, my name is Forbes McIntosh. Can everyone hear me okay? I'm a lobbyist. I'm a lobbyist in the long-term care arena, among other things. I do represent RSA Wisconsin, which is the Residential Services Association of Wisconsin. These tend to be providers of all types, but predominantly serving individuals with intellectual and cognitive disabilities. I also represent other long-term care groups, including assisted living on the elderly side, and I also represent a number of nursing homes. I've been doing this since about 1996. So that means like many of you, I've been around since the inception of family care under Governor Tommy Thompson. I always kind of preface my comments with, keep in mind that a lot of times when I'm arguing the dysfunctionality or areas of family care or long-term care system that I think need improvement, that Wisconsin is ahead of the game. We're way ahead of the game as compared to other states, which is a good thing. I remember back in the early 90s when institutional care was pretty much the only game in town of where a person could go. But today, our profession has changed a lot. If you look at what the nursing homes are today, they're nothing like what they were 30 years ago. They tend to be rehab facilities of predominantly people coming out of hospitals. So the whole idea of keeping people out of nursing homes today that's not what family care, it's what family care started from, but it's not really the agenda so much today as it is serving people that have needs that don't require the nursing home care. But as these discussions occur and you hear the compliments from some stakeholders and frustrations by others, and I certainly represent stakeholders that would say they're frustrated, note that the frustration is coming from the people that provide the actual hands-on care. That's who I represent. I represent the owners, the operators, the folks that are providing the hands-on care in residential settings. So whether that be a CBRF, an adult family home, a group home, those are the people I represent at the Capitol. I've said it before, but there is room for improvement. I remember times when there were waiting lists, and there still are under the current legacy programs. And then we're getting beyond that, which is good. But the discussion is switching to reimbursement rates and making sure we're providing quality care, quality living for individuals in the system. And how do you ensure that? Because from my perspective, I have some providers that are actually happy with the provider rate they're getting from the MCO. But I have a lot of others, and that's predominantly in the intellectual and cognitive disability side, the behavioral side, where they would say it's not enough. You know, they'll argue that, you know, when you say free market, you say business, competition, great words, words I use in my other areas of contract lobbying and business and industry, sounds great. But there tends to be a clash of ideology when it comes to providing hands-on care to individuals. I had a discussion recently with a provider who is in a contract negotiation with an MCO. And even though I'm going to bring up the MCOs and DHS, please know I have a great amount of respect for them. Again, this is always going to be an ideological discussion. And when we're dealing with businesses, we're also dealing with people. And when it comes to the cognitive and the intellectual disability side of things, it tends to be 100% managed care or family care. And when something's 100% family care, and the MCO, if there's not two MCOs in the area, it's just one, there's only one game in town. It's a monopoly. Whether you like to call it that or not, it's a monopoly. And if you're a provider, especially if you're a small provider, which most of them are, you don't have very much leverage with that MCO. And I'd say that's one of their major complaints, because how do they negotiate when they have nothing to stand on? And if they're given a rate, whether they believe it's below the actual cost of providing care and providing that person the quality of life, their arguments in their minds just fall on deaf ears. I know that's not the case of the MCOs, because I talk to them and they're caring people as well. But from a provider standpoint, how do you get beyond that? When it comes to business, business comes down to leverage. That's it. And this discussion I had with an organization, a religious one, I had to use the term, and frankly, you have to be a little bit more ruthless, because that is also a business terminology that's key to competition. But how do you explain to someone that when their focus, especially if it's a religious focus, is caring for individuals and not scaring them, and pushing them away, or making them believe that you're going to care for them, but at the same time you may lose them because you can't provide the care? That's kind of the circumstances I find my clients in, especially on the behavioral side. It's 100% family care. There is no other game in town. There is no private pay. When I'm working on the hospital side of things, we just cost shift. It's great. We have insurance, we have private pay, we have Medicaid, and that side, I don't represent hospitals, I represent other providers within that system, but we can cost shift because there's a place to cost shift too. In family care, there isn't. On the nursing home side, you can cost shift a little, but you know, it's about 70% Medicaid. When it comes to the elderly assisted living, there's a greater percentage of people that are private pay, so you can take a few low-paying family care residents and make your books work because you have other high-paying private pay residents. But when it comes to intellectual and behavioral issues, it's 100%, and that becomes a problem. When driving down costs becomes the predominant factor and the ultimate goal, it becomes a bigger problem, especially for the providers and the people we pay to provide the hands-on care. And that kind of leads me into the next talking point, is our direct caregivers. even though RSA focuses or is represented by our owners and operators, most of our discussion is about what do we do about our direct caregivers. They're the people that we're supposed to be valuing the most, to provide that care, to clean people up after they had their accidents, whether getting them to work every day, getting them their transportation, feeding them. I've been doing lobbying for about 20 years, and I said this to a legislator just last night. I said, sometimes I get frustrated because I look at whether we're a road builder, whether we're looking at different agencies from our public lands or our utilities, whatnot, what we assume those people should be making versus a direct hands-on giver, it's very lopsided, and I think everyone here knows that. And I'm not saying it's fair, or I should say unfair, that those other individuals, whether they're operating equipment on a roadway or whether they're holding a sign that says slow and go, I'm sure they deserve their paycheck, but I think the direct caregivers also deserve to be valued. And I think we need to keep on having the discussion, and I have it with Brian and others. And I think we're all trying to figure out the balance test of who pays for all this? The taxpayers do. So now we come into another balance test. How much is enough? How much money are we willing to spend? When I look at DHS and its leadership, they bring up a valid point. We don't have unlimited resources of funding. But I do think even though when it comes to the capitation rates, we do have certain assumptions that go into creating them for the MCOs, and we have the functional and financial screens to prove whether a person is poor enough to receive the care and whether they have the functional needs. We also need to be setting some bars, because always driving down for the business philosophy of competition does not work in a monopolistic system. When someone has all the leverage, it doesn't work. And I'm not bad-mouthing the MCOs, because I think they, in turn, might want to pay our providers and our direct caregivers more money, as long as they can show to the department and then the department to the legislature that those costs are necessary and needed. It's always devil's in the details of how to get to there. But, what should a provider be making? I think we need to be having that discussion. What is an adequate wage? I know that saying living wage is a difficult thing to say in this arena today, but what is an adequate wage for someone providing 40 hours of care to individuals with special needs? Do those people deserve health insurance? Well, with Obamacare coming forward, if you have over 50 employees, guess what? As a provider, you're required to now. But these are all discussions that we need to know. Are they truly having an impact in the capitation rate setting, and are we actually getting enough out of the rates out of the MCOs? And it's become a more difficult argument, because 10 years ago, I would just lead a charge of individuals to the Capitol and go to the legislature and look for percentage rate increases. We're in a much more complex world, and the discussions we're having are more complex, and trying to educate our members, and especially the individuals we serve, it's become even more difficult. But based on the level of complaint that I'm receiving from my residential providers, especially the smaller ones, there needs to be some kind of change or recognition. I'm not saying we're going to go back to the allowable cost policy, because I think if I'm the MCOs or the department or others, I'm going to say that there might have been abuses by the providers charging too much. But when it comes to behavioral needs, there's obviously a problem, because it's too loud and clear of a complaint. And we've got to figure out a way to get beyond that. And the associations are working with the department and others to ask the right questions. But when it comes to the behavioral side of things, there are issues, and there's definitely room for improvement. I'm not sure what my timetable is.
We got a few more if you need it.
Okay. Well, I'm probably going to end it and then do questions, but I always kind of give this point, and it's one, can be kind of corny, but it's kind of true. With legislators, more and more, I'm having them walk a mile in their shoes, meaning I want them to come to our facilities and just spend a day or spend a few hours with the direct caregivers and with the individuals we serve. Walk a mile in someone's shoes, you'll learn a lot. You begin to figure out their perspective. Most of the time, the legislators come away going, I can't do that job. I could never do that job. I can't believe these people are doing that job for the amount that they get paid. They're saints. The problem is we pay them like they're saints. And I'm not saying it's going to be fixed overnight, but it's a discussion that needs to be had. It needs to be had loud and clear. And we need to come up with we need to value the employees that provide these services. And I'm saying I think we're trying, but when I look at other government contracts in different areas, we seem to value other employees of different job types a lot more than we do the people that give direct hands-on care. And I'll leave it at that.
Good morning, everyone. I'm really excited to be a part of this conference and to talk about the direct care workforce. And thank you, Forbes, for really highlighting again and setting the tone regarding the value that direct care workers bring to long-term care. Again, my name is Todd Costello, and I'm the chair of the Wisconsin Long-Term Care Workforce Alliance, which is really a statewide association of a very diverse group of members representing advocates, individuals, agencies, from personal care agencies to nursing homes, assisted living facilities, the full gamut. And the one thing that we have in common is that we all employ direct care workers. And, you know, when I think about long-term care and I think about all the wonderful, innovative plans that have been made, I just immediately go to the fact that these plans are actually on the backs of this direct care workforce, because without them, it won't work. They won't be there. And when I look at what is working, I think we have a very, very strong commitment in the state of Wisconsin to our long-term care recipients. And there's been a financial commitment. I believe we've spent close to $2.8 billion, according to the long-term care sustainability plan, some of the data that we've been researching, and that about $224 million of that was for personal care and home health services. And so when we look at direct care workforce and we look at the cost, and I think that there's been this concern that it's growing, and it's a workforce that has inconsistent training. There are concerns around fraud, perhaps, and abuse. It's a workforce that's also representative of family members. In our particular agency, about 40% of our workforce are family members, and with that there comes great comfort for family members who can take care of their own, but there's also concerns in terms of their own health care, and it's a segment of the workforce that has higher incidence of divorce, cancer, heart disease. They are often passed up for job advancement because of inconsistent work history, and they make a decision to stay and take care of their own. And it is something that I believe there's some controversy and mixed feelings about that whole scenario. When I talk to family caregivers, their biggest fear is that they will die before their child or spouse, and then who will take care of them in the way that they feel is necessary. When I meet with direct care workers, and we hold various focus groups, and at our particular agency, we randomly select our workers and invite them to lunch, and it's just really a meet and greet. And it's an opportunity for me as the executive director to have a better understanding of what their work experience is like. And I can honestly say 9 times out of 10, the first thing out of their mouths is something like, I just love my, my consumer. They're a part, I feel like I'm a part of their family. And that's when it works. When we look at the expenditures of our operations, 92% of our expenses is for our direct care workforce and our workforce in general. And it's really about people. And with people, it's about relationships and the value and the effectiveness of that relationship. But as we all know, relationships and people, myself included, we're messy. And there is a lot of challenges in working with people and working with consumers and looking at the skills that this workforce needs to be effective. They are the closest to the individual. I think in many cases it's what matters most. We have a number of our board members who are consumers, and their biggest struggle is how to find and keep qualified workers. And having their services disrupted is really, it's a threat to their well-being. It keeps them from having the meaningful day that we all talk about. Just to be able to do what you choose, what you want to do, whether you want to wear a blue sock or a white sock or a red sock, it's really sometimes down, to these individuals who are there caring for you. And there is, I think, a lot of really good, when I look at what's working, I think it really comes down to our state's commitment to long-term care. Really looking at family care and the fact that it does reduce costs, and that and the fact that such a large percentage of the population, the recipients of long-term care, actually live in the community, actually live in their homes, and that is, in many cases, a less costly option. We have 90,000 direct care workers in the state of Wisconsin. It is one of the fastest growing occupations, exceeding nurses, physicians. But yet, when I think about the workforce, and at CLA we currently probably employ about 1,000 of these individuals, but some days it's like water everywhere, but not a drop to drink. And so we have them, and to just talk about what their day may look like. Many, just to achieve an 8-hour workday, have to begin perhaps at 6 o'clock in the morning and work clear to 10 o'clock or 11 o'clock at night. We're looking at very part-time, inconsistent hours. Authorizations come in at an hour or a half hour. It may be 4 hours one day and 6 another. And with the sort of decline in the number of authorized hours that we're experiencing, we're really finding it more and more difficult to find direct care workers. And oftentimes this is where when family care or family members step in because they're in the home or they're in a relationship with this individual, and they can fill in for those half-hour shifts or 1-hour shifts, because for the workforce, quite honestly, when you look at the cost of mileage, they can't afford to do it. And that's just one of the realities. And so when you look at, this great workforce, 90,000 strong, but yet they're not really as available as they need to be, as the needs suggest. The other really astounding statistic that I find disturbing is that out of this 90,000 workforce, 43% are receiving some form of public assistance themselves. And so for me, it's a disconnect there. And there's an opportunity, I think, where we can improve that. Looking at wages, looking at benefits. Also, it's a workforce that may not get any paid time off. And I don't know about you, but I need a day off. Not always even a sick day, but perhaps even a sick of it day where you just need to, chill out and take a deep breath. And they often don't have that option. And so, they're closest to the individual. They're what really matters, but yet they are oftentimes the least paid. And even by design and structure, they're also the least supervised. When you're looking at MA, it's a 50, 60-day supervision visit. A lot can happen in 50 or 60 days. And, it's one of the things that keeps me awake at night. You never want to be the agency that has, the frontline heading that, some poor outcome or some sentinel event was because, your worker wasn't available or didn't show up. And so it's looking at how do you manage that? How do you create the quality and the integrity? And how do you find qualified workers and cultivate them? Most of our clients want a 20-year-old UW student. If they could pick their ideal worker or student from the... Right. Exactly. And it's what parents want, it's for their children, it's what individuals want. They want folks who are perhaps on a career path in other, perhaps other fields, nursing, special ed. And so we're in a position where we really have to cultivate this culture of excellence and raising the bar for training, and also just value. I think there's a wonderful opportunity to launch a campaign that could really speak to, have you thanked a direct care worker today? Placing value on caring, caring as a career, because at the heart of what is offered is that, we can teach you to wash your hands, we can have all of our standard precaution trainings and preventing needle sticks, but caring, that kind of, it just comes from a different place, and it's expressed in very different ways and through all kinds of cultures, and it's just really wonderful to watch unfold when you talk to these direct care workers and the people that they serve, and when it works well, at the core of it, it is that caring. And can you put a real price tag on that? And it kind of sounds hokey, but if you were to leave your child, your mother, your husband, your spouse, sibling alone, we're talking about vulnerable people, and who do you want to step in and care for them? And will $9 buy you that? Will $10 buy you that? Where do you find them? How do we keep them? How do we convey that we value them? And at the end of the day, we're forced with balancing the costs of business, the really wonderful opportunity that the Affordable Care Act offers in terms of health insurance, and just the dissonance that has created for many providers. Who would want to say to your workforce that you're not worthy of health care? But yet the costs for many of our providers, it will close their doors. It will absolutely close their doors. And so you have this dissonance, of this workforce that you value in one hand, and a set of policy and expectation that, again, by design is wonderful, but you can't make it work. You can't make it work. And the message, I mean, the message that we may be giving this workforce, because people are innovative and realize that perhaps one way of addressing that is to not hire anyone working more than 30 hours. So again, you're watching this marginally paid workforce now being at risk of even working less hours so that they would not be eligible. That's not right. I mean, it's not right to put them in that position, and it's not right for businesses who come to this with integrity to have that be the message. There's an opportunity to do something different. Training of the workforce, again, I think that the turnover rate for direct care workers averages somewhere between 35%, and some of our members report as high as 50%. And at the core of it, a lot of our direct care workers really want more training. We're really excited about the department's initiative looking at dementia care and providing training. And one of the things that's really exciting that we're involved with right now through the Workforce Alliance is that we've put in an application for the Fast Forward grant that would allow for direct care workers to, in partnership with the Alzheimer's Association, to provide dementia care in the home. In addition to that, we're working with the technical colleges that will offer 1 credit towards earning the CNA certification for those who complete the orientation and this training. And the other piece of it is that the training could be more consistent, and there's an opportunity to have consistent, portable, statewide training. And that's really, I believe, what's needed. I think there is such inconsistency around training. There isn't a real certification process for direct care workers. So how can we raise the bar and their value, I think, by really giving them the tools to be successful. And oftentimes one of the main reasons why people leave positions is they don't feel that they have the tools to do the job. As an executive director, it's one of the things that I feel very strongly that, for my workforce, I have to give them the tools to succeed. And here's a workforce that, is not feeling prepared because, as I had mentioned, these relationships can sometimes be messy. And so let's look at training that not only addresses dementia, but really looking at mental health, looking at communication. We also serve a lot of children with autism. There's another opportunity, again, very vulnerable population. Having specific training, I mean, the need is there, but I don't think that the skills are as well developed as they need to be. And certainly what the future suggests as we look at the shifting demographics and the number of our citizens that will now become part of this long-term care group. In 20 years, we see the aging population doubling. I mean, that's tremendous. But we're not seeing the workforce double. The workforce is only projected to grow by 4%. When you're seeing 50% increase, there's a disconnect there. I think that's the reason why we're all here, because we're really wanting to plant seeds for the future, but yet our present set of circumstances, again, are leaving us in a less than desirable position. When I think about where we could transform this system and where we could potentially go as a solution, it really comes down to providing training for the workforce, finding ways to recruit them and to keep them, and to create career ladders and perhaps stacking of credentials that it can be the entry level into healthcare that would allow them to then transition to a CNA, nursing, special ed, and other agencies. There's also, I think, a need for just a public awareness. The reality is that most of us will either be a recipient of long-term care ourselves or a provider of care. And I think being able to normalize that and to understand and to begin to promote an awareness early, from middle school, through high school, and to normalize it in the workplace. When I look at the sandwich generation, and we're looking at our employees that are caring for elderly parents and trying to sustain their own salaries and careers by remaining in the workforce, there needs to be education for employers to recognize the stress that caring for someone brings and how that may impact performance, and looking at how we can create a work environment that actually supports that understands it. I think there's a lot of opportunity to also work with our clients and consumers in the variety of settings in which direct care workers operate. As I mentioned earlier, that there's a significant percent that actually remain in the home, and the home now becomes a workplace. And there are certain expectations. I mean, we have to provide a hostile-free, safe work environment. The home now becomes that, and educating consumers to maintain that and to understand that and to provide that for our direct care workers. I think there needs to be opportunities for direct care workers to have a voice. That's one of the mission behind our Workforce Alliance, is really wanting to hear from them directly what we can do. Our roots are early, as Thomas had mentioned, in the independent living movement, and one of the things that resonates is nothing about me without me. And yet all day long we're making decisions about this workforce that they're not really around the table. And even at our Workforce Alliance, we struggle each month, how do we get more direct care workers to attend? And the truth is they can't afford to, because they can't afford to take the time off. And that's just one of the realities. And so as we look at all the wonderful places where we can go and just what this dedicated, and I really want to emphasize that there is such strong dedication from these individuals and what they offer some of our most vulnerable citizens. It's really quite powerful. And unless you're in a situation where you are having to look for a direct care worker to address a family need, the realities aren't as present. I mean, when you're caught in that moment of who will care for this person that I care for, you begin to look at this workforce very differently. And you want to know with some certainty that they're trained, that they can do the job, and that you can leave your family member alone with them. I mean, it's really that simple and that basic. And so when we look at long-term care and this workforce, I think about the opportunity in terms of the training that could be available to support the growing need, looking at how can we demonstrate and place value on this workforce. One of the harsh realities is that the Medicaid rate has really remained flat for about 12 years. There's only been a 2.5% increase, the last being in 2008. And yet the cost of doing business, the cost of recruitment and retention, given just the turnover, exceeds that. And we're approaching the point where it's not paying for itself. And so there's little opportunity for any cost shifting, so to speak. And so when we look at the growing need and we look at the supply of those individuals who will be available to meet that need, I believe we're headed towards a crisis. And we do have an opportunity, I believe, now to begin to plant the seeds to address the future needs.
Good morning. I'm your cleanup speaker this morning, it sounds like, in this panel. I want to talk to you a little bit this morning from the perspective of the aging units and aging and disability resource centers, and talk to you a little bit about where I come in from and where my biases might be. I've had an opportunity to work in a nursing home. I had an opportunity to manage a group home for people with serious mental illness. I worked in an aging unit and then an aging and disability resource center as the director, and was a service provider within the family care setting, operating an adult day center, prevention programs, nutrition services, transportation services. So we had an opportunity to be on that side of the table as well. And I also had the opportunity to be a family caregiver and someone who was reliant on the important services that are available in the long-term care system and how important those supports are. So, you know, when I hear all of you talk, I have all of these thoughts just kind of swimming around in my head from those various different perspectives. The long-term care system is obviously incredibly important to an aging population. For us, first and foremost, when I think about what's working and how far we've come from when I first started working in both the field of aging and working in the county aging unit, is that we now have an aging and disability resource center in every state in Wisconsin. And we now have the ability to start communicating to people where to start this somewhat complex and confusing process, that people will now know where to go. That 57 and soon to be 64 of the 72 counties in Wisconsin and all of the eligible individuals who live in those counties will have access to community-based long-term care services. We've come a long way. We've really come a long way. And that within those counties, member satisfaction is high. Programs have proven to be cost-effective. Participants have opportunities to self-direct their care. People have choices, and people are getting served. We're not looking at waiting lists of hundreds and thousands of people. All of that said, have we solved all of the world's long-term care problems? Of course not. We have many things we want to accomplish yet, but we've come a long way, and certainly in the time that I've been involved. In preparing for today, I spent some time talking with consumers, some of the aging and disability resource centers, and even some of the managed care organizations that I work with. And one of the things that came up regularly that we haven't heard much about today is sort of the other partner in all of this, and that's our economic support folks. I heard some concerns about the economic support consortia and the lack of user-friendliness around that, not the workers within that, but the process that has not proven to be very user-friendly for either the individuals or the agencies who need to access those. When we first piloted aging and disability resource centers and then family care in the county that I'm from, back in Portage County, when we had a problem working through the system, we were able to sit down with all of the stakeholders in that process and work out a system that would make it work for the consumer. We could all get around the table and develop policies and processes to make things work. We're not able to do that anymore with the consortia. And in long-term care, what we've heard all morning long is it's about relationships. It's about having a connection with somebody who understands you and your unique situation. It's no different in establishing the economic eligibility, particularly when we're talking about the elderly, blind, and disabled population for medical assistance. The spousal impoverishment issues, the issues of rep payees, the disabilities, and all of the other issues that can compound getting that process completed makes it very, very important to have people who know you, people who've worked with you, people who can work with you from start to finish in that process. And if you've had an opportunity to call the consortium number and try to sort through, you have to understand the language, you don't get a direct answer to your question right away, people will get back to you, the process takes longer. So I just want to throw that out there as something we want to think about, because we play that disenrollment and re-enrollment game a lot for people who were eligible all along, and it's upsetting to consumers, and it costs a lot of time and money for the system. So I just want us to not forget about that. For the managed care organizations, particularly in those areas where we have multiple managed care organizations working in a region, to start thinking about, they now have a lot of different processes for working with providers. Each one perhaps has their own way of negotiating contracts and reimbursing for services. For providers out in those networks, you spend a lot of administrative time trying to manage how to make that work, and it's difficult in the environment with one. It's much more difficult if you have different processes for each of those. So to start thinking about that. You heard a lot about provider rates. Certainly I think I would agree that we're at a tipping point, that rates have been reduced or kept low to keep the cost of the system down, but providers are unable to cut back anymore. And our long-term care system must be adequately funded to ensure that workers are paid a decent wage and have benefits, and that we don't see turnover at the rates that Todd was talking about. It's all about quality of care. It's all about relationships. And when you talk about the nature of the work that these workers are providing, you have to have trust and you have to have relationship, and we can't afford to have a revolving door of workers coming in and out of people's lives. We hear a lot about an increased emphasis on and focus on natural supports. We know that 80% of the long-term care is already provided by our family caregivers. And as an Aging and Disability Resource Center, we knew that when families were coming to us to ask about assistance, generally speaking, it's because they were already maxed out. They had been doing this for a very, very long time. They juggled all the things they could juggle and were right at the wall. And so I think we need to be thinking about and cognizant of what can we do to be more supportive of caregivers, because there are partners in all of this, those informal caregivers who we need to continue to embrace throughout this process. So what do we do to make sure that we keep them engaged throughout this process? And as we all know, enrolling in a publicly funded long-term care program does not make the life of family caregivers just stop. Their role doesn't just then go away. They continue to be caregivers and they continue to be family members, and we want to help them find that balance. However, that said, the ratio of caregivers to individuals needing care is going to continue to decline. We are looking down the road at moving from a ratio of about 7-to-1 to about 3-to-1, and we're not going to have enough of those folks to go around. 49% of our American workforce is expected to be caregiving within the next 5 years. Has a tremendous impact on our workforce to have individuals who have tremendous caregiving responsibilities, sometimes long-distance caregiving responsibilities, working in our places of business. Many of those adults are part of that sandwich generation that you heard about, that are not only caring for a parent who's 65 or older, or raising an adult child with a disability, but perhaps have younger children at home that they are supporting as well, financially supporting, physically supporting, and emotionally supporting. That's a lot to be juggling. The number of caregivers is not growing nearly as fast as the number of people with cognitive issues. The cost of caring for an elderly parent is staggering, both for employers and caregivers. And as you heard earlier, family caregivers are less likely to seek preventive care for themselves, a choice that could manifest itself in additional time away from work and additional expenses down the road. So we further compound the problem by having caregivers who are unable to take the time, unable to have the time and resources to then take care of their own needs. And this lifetime of caregiving, this can occur over decades sometimes, that individuals will need care and medical attention, and that sometimes makes it really difficult to use current benefits that might be available, such as the Family and Medical Leave Act, when these caregiving responsibilities can be sporadic in nature, they can be continuous in nature, but they can sometimes occur over very long periods of time. You heard a lot this morning about the increase in the population with Alzheimer's or other dementias. Nearly 15% of our caregivers for people with Alzheimer's or dementia are long-distance caregivers. The out-of-pocket expenses for those long-distance caregivers are nearly twice what it would cost for a local caregiver. One of the things we haven't talked a lot about today is isolation. Successfully aging in place or being able to remain in our community is about meeting our long-term care needs, but it's also about addressing our quality of life goals. We have a number of individuals in our community who are at risk of losing their supportive friends and family, the meaningful activities that they engage in, their opportunities to socialize, the necessary supports and resources to maintain their health, transportation, access to health services and other information, are leaving them isolated from their communities and disengaged. People who are isolated are linked to having higher blood pressure, are more susceptible to illness and infectious disease, and also have a loss of impulse control, not being able to resist other unhealthy foods or unhealthy behaviors, and have an earlier onset of dementia. The cost of isolating our populations because we do not have adequate transportation systems, adequate resources to keep people doing the things they love to do and engaged in their communities have long-term ramifications, and we don't want to be penny-wise and dollar-foolish when it comes to looking at the quality of life issues that are so important to helping maintain people in a community. Isolation has a larger social cost as well. Just like everyone else, individuals in our long-term care system have skills, talents, knowledge, and much more that can enrich the lives of those around them. We want to keep folks engaged in our communities, and it's our loss to not have these folks involved as well. Increased number of long-term care consumers places a pressure on community supports in our, we talk about transportation, we talk about other home and community-based services that exist in our community for those that are maybe just above the income limits for long-term care services, and we have not spent much time thinking about what kinds of increased resources do we need to place on those systems to support the growing need for services in those systems. We have an aging population, but we also have an increased population living in the community that needs access to those services, and we have not shored up those resources to meet that growing demand. Volunteer management and funding to maintain the home and community-based services, our increased reliance on volunteers. Right now, we're faced with some federal funding cuts potentially for our volunteer programs. The need for state and local support of volunteer programs, our increased reliance on those programs to continue to do the work that we do, it will only continue to grow, and we need to make sure that we keep those shored up as well. Technology can be very isolating for folks that don't use it. We have the haves and the have-nots. If you're younger, if you're affluent, if you're more educated, you're more likely to have access to it. And increasingly, and I know this was a real issue at the Aging and Disability Resource Center, the way people learned about or accessed benefits was increasingly online. And it's great for those people who have access. It's not so great for those that don't. And to make sure that that kind of information remains available to everybody is a responsibility of all of us. 41% of our folks still do not have internet access at all. 53% of the folks in the recent Pew Research study did not have broadband access, and 23% didn't even have cell phones. So as we move to increasing operations and tasks that are online, we need to make sure that those who need those materials and access to those materials won't be cut off. And the folks that are unable to leave home, who might benefit most from maintaining social connections, might be able to at least afford the technologies that allow them to do so. In terms of what we would recommend for improvements going forward, we'd like to see the creation of some singular processes between managed care organizations and providers. We'd like to see an expanded use of strength-based assessments and care plans and building plans around what works and how to sustain that for individuals. Some core standards, not just contract language, but core standards around employment and self-direction for all publicly funded long-term care programs. Increased funding and support for some of the safety net programs, the Older Americans Act programs, transportation services, et cetera. Expansion of Family and Medical Leave Acts to include individuals caring for grandparents as well as grandparent caregivers, and promotion of paid family leave so that we don't have caregivers who have to make those difficult choices. Development of a next generation workforce that's fluent in aging and technology and is going to be critical to the lives of older adults and caregivers. We heard a little bit about educating stakeholders on how managed care works, and I would argue that we also need to continue to create venues for stakeholders to educate policymakers on how long-term care needs to work. In the future, we'd like to reach the point where very few people will say they didn't know where to start the process. That older adults will not only have an impact on the system and what needs to be available, but will also be viewed as a strength. We talked a lot about a shrinking long-term care workforce. We will have a growing number of older adults and retirees who need to be looked at as a resource and a way to be part of the solution. Technology is our friend. ASA just came out with the top 10 innovations. We need to work to get that technology into the hands of individuals and caregivers who can make good use of that technology. We need to work with our universities, our technical colleges, to make linkages between our aging and disability services and our technology providers, and create education and research around how to remove some of those barriers to that access. We need caregiver-friendly work environments and employment benefits packages that will continue to support family caregivers. We need to expand the use of group caregiving models such as Share the Care that are simple and effective, and recognize that it's really going to take all of us to meet this growing need. We need to continue to focus on prevention, early intervention, our health promotion programs, and we need to think about livable communities. You know, we talked a lot about dementia-capable systems and dementia-friendly communities, and those are all really important initiatives, but when the day is done, what we really need is communities that we can all live in, regardless of our age, regardless of our ability or disability, to be thinking about things like universal design and communities that will work for all of us to allow us all to continue to age in place. So I really thank you for this opportunity, and I'm sure we all are open to questions.
We had another speaker on our agenda, Nino Amato, and I just want to read you a text message that I got from him. It says, Thomas, a friend is flying me up to Green Bay for the conference, and one of the two engines started to malfunction 20 minutes into our flight. So we had to turn back to Madison to get it fixed. I've looked into another friend's plane, but he flew out yesterday. This, by the way, I got this at roughly 9 o'clock. So, long story short, he didn't make it. He's not here. I think we've had quite a morning. It's been informational. We can get to questions in a minute, but certainly we've heard about how the state is trying to become more dementia capable. We heard about legislative achievements in terms of instituting the Silver Alert system. We heard about trying to integrate behavioral health aspects in for long-term care consumers, including the revision of the long-term care functional screen. We had good discussion on the expansion of family care in the 7-county area in northeast Wisconsin. We certainly heard that there is a need really to look at the capitation and funding for MCOs to make sure we're not missing things related especially to behavioral health, and those two kind of things run together. Provider rates was a concern, especially as it relates to the ability to pay the workforce, to value them, to make sure that there's appropriate training for the workforce. I heard technology and Janet's presentation. I don't know if you've seen those Japanese robots, but maybe we will have a technology solution at some point in the future, although I think person to person is probably going to be the way we go for a long time, so we need to really look at that. In terms of employment, I think we heard about the better bottom line, the blueprint for prosperity, Wisconsin Fast Forward, and some of the great opportunities that are going to exist for increasing integrated employment. The recognition we received for some continuing role for center-based employment was good to hear. I think that we value the discussion that revolved around partnership between those organizations that provide employment and state agencies. That partnership is part of what this conference is all about. It's the one conference in the year where we bring together all aspects of employment going forward tomorrow and Friday. We heard about partnership in terms of wanting to get more providers involved with Project Search expansion, Promise. In short, I think we got a pretty well-rounded view of some of the major influences and concerns related to long-term care. We have this great panel sitting here that can answer any questions or react to comments that you might have. We have that microphone back there available for people who want to ask questions or make comments. So let's see if we can wrap it up. We have lunch, again, will be served buffet style over here at the conclusion of this section of the forum. We have one of our our Attorney General candidates, District Attorney Ozan, is in the back row there already, and hello. And we have Representative Richards on his way, so they will be our lunchtime speakers at the time in which most of us have finished our meal. And then afterwards, if there are any people who want to stay for making comments about, along the lines that Janet just did, with suggestions on how to improve the long-term care system, we will continue to video record those comments and make those available, hopefully on a YouTube upload pretty soon. Also, we know that following the lunch that the RFW in Action personnel who are here, CEOs, executive directors, and so forth, who want to join us for a discussion with Brian and Janet, we will be meeting in rooms 5A and B, which is right up in this hallway right here. So with that, I will open the floor for questions. Comments, anything?
Thank you.
It's not going to, it's
It is
only
on.
for the camera.
Okay. Well, this is my opportunity to make a comment.
You might want to come up here.
Todd, your comments, your presentation, I've heard various, at various times, I've heard similar comments. I thought yours was particularly poignant. The cruel irony is that we depend, some of us may depend on care later in our lives to be provided by people who do not have access to the health care that we require, or for that matter, the health care access that they're providing. You know, of all the challenges facing us as state policymakers and overseers, I think that ranks up there with one of the top ones. It's very challenging. I'm just wondering if you could elaborate in terms of, have you taken that further into potential solutions, potential strategies for changing that? I'd like to hear that.
I think, if we were to envision the future and how we might improve, it really is looking at some opportunity to create statewide, consistent training, which would follow the worker. I think the costs of training and orientation is really, given the turnover, if we could have training that was portable, that was recognized, that was consistent, I think that would be a beginning. A registry.
What about healthcare in particular? I think that's
In terms of healthcare for the workforce, I know that many agencies already offer for part-time employment or greater healthcare, and our agency provides that. With the Affordable Care Act, of course, it will require it to be affordable. We right now, just to give you a comparison, we offer health care, but out of the perhaps 400 individuals who would be eligible, I would say less than 80 actually elect to have that benefit because the wages are so low that they can't afford the premiums. So I think that, we're working with, through the Workforce Alliance, we're looking at the opportunity for some group purchasing of health care and seeing if we could look also at workman's comp and how we can impact training to prevent injuries to the workforce and using sort of this collective to come together and look at how we might have some purchasing power more so as a collective. I think that because Affordable Care Act has been sort of a moving target when it was going to be implemented, we've had a lot of momentum and that has kind of waned. But I think that's one of the major concerns. How can we provide this workforce with those benefits, and who will pay for it is sort of the biggest dilemma.
I could add something. I'd just like to add that it's a concern of the RFW in Action membership as far as how to deal with the Affordable Care Act mandates related to employment insurance. And we've tried to get some clarification around, is there a way, and this might be something that Department of Health Services might want to explore, but we've made this proposal at the national level to access the National Association of Disability Service Providers. And one of the things that concerns us is that we have services that are being funded by Medicaid long-term support dollars. And people who are contracting under those then get hit with employer penalties if they don't offer insurance at a certain level. And what we're saying is that the penalties really should be looked at very closely and maybe even set aside for the long-term care providers of various kinds. And maybe that's a way to try to, I think the latest, we've heard repeal, replace, and now the latest thing we're hearing is reform of the Affordable Care Act. And perhaps that is one area in which the ACA could be reformed, and perhaps Governor Walker, Secretary Rhodes, or others could be useful in terms of saying, well, you're paying us with Medicaid dollars. Perhaps it doesn't make sense to penalize us then on top of that for not offering all the insurance that we're expected to offer. In other words, there are people who are trying to do the best they can with their insurance policies, but if they're not being paid to provide those coverages, then it's going to be a regulatory issue, I think. So there may be some ways to work with that, and in the penalty phase specifically. Those are IRS regulations.
I appreciate the relief to employers that could bring. And, you know, that's an interesting proposal that still does not address, you know, our challenges from what I'm hearing. It's the attraction and retention of a workforce.
Well, the penalties actually do address that because your penalties are triggered by somebody approaching the exchange and getting insurance through the exchange. And so what it would permit is people to approach the exchange and get insurance and not have the employer be penalized.
Good point. Yeah,
So.
that's a good point. We still, you know, even with, if I just make this other comment, even with, getting some exercise here, even with the ACA, I'm just commenting on that this is a really perplexing issue for us. And I say us, all of us. Because even with the bronze plan, the lowest level of plan under the exchange, that's designed to cover on an aggregated average, 60% of health care costs for an individual. So, you know, the pay scales are low with our workforce in direct care. And it's just something that I'm very interested in. The solutions don't come easily here, and I'm really interested in more dialogue with the provider community on this issue. I wish I could offer anything more along those lines, but at this point, I think at least having dialogue about this, I would look forward to that. Thank you.
And I was just going to make one other comment. I think, you know, working with the department on a lot of the issues, nibbling around, a lot of it's going to be around the edges. But frankly, it's going to have to go to a higher authority, which is the legislature, because when you think about it, okay, if I'm in a primary care system, the reason they can afford to provide health insurance to their healthcare employees is because they're predominantly private paying insurance. They're private employers. The reason I can afford to give health insurance to my employees if I need to, I don't because I'm a small company, but it's because I'm a private business, private dollars. The problem comes in nursing homes. 70% Medicaid, the other 30% is Medicare private pay insurance. When I look at assisted living, if it's on the elderly side, it's mainly private pay, so they can afford to provide the benefits. When we get into the behavioral health, the problem comes in because it's 100% Medicaid or Medicaid waiver. There has to be a recognition when Medicaid, the state and the federal government, but mainly state because we're the leader of it, when we're 100% of the pot of the money that goes to run the system, we should be about 100% of the share of making sure those people can afford health insurance. And on the nursing home side, they should be 70% share because they're 70% Medicaid. The problem is, politically, that kind of money, that's a lot of money. But unfortunately, because there isn't a private market to go to, there isn't a business scale of, you know, you're going to pay this because this is what the market demands. Because there's lacks of market, because it's Medicaid dollars, a lot of it's going to have to be borne by the state government and the federal government matching share. And I think that's how we're going to have to solve the problem. But I know because of how expensive that's going to be, we're going to have to, as you alluded to, look at different perspectives and trying to take this in different ways and not just one big gulp. But I wish we could just make it, and it's probably predominantly up to me and my folks, because I'm a lobbyist, trying to get the legislators to understand and the administration. This is an issue that needs to be paid for by the major payer, and making sure the capitation rates for the MCOs are adequately funded to deal with that, and to make sure that we are actually getting the right wages to our employees from those raises.
I just want to add one more point to that. Excuse me. As recent as actually February, there's a group of our members that went to Washington to speak with IRS and members of CMS, and at the core of our message, we were really looking for an opportunity perhaps for exemption for Medicaid providers whose revenue was generated by 85% of Medicaid dollars, and looking at an exemption from the penalty, but also it would allow for the workforce to access the exchange. And it was well received. We're not quite sure what the follow-up will be, but again, when you're looking at the majority of these providers whose revenue really represents the bulk of the revenue is really Medicaid dollars. And we're also looking at, these are actually, behind the Affordable Care Act, the very workforce. The argument could be made that they actually belong to Medicaid and Medicare, and that, we're actually doing a disservice to our own employees. And again, that's a disconnect in the message and the reality of this.
And of course, that the pressures that are on both state and county government.
Right.
There are tremendous pressures on that, and using property tax dollars, state GPR dollars to provide that match.
Could you reflect that for the camera?
Would you like to maybe just restate that so that folks could hear that?
I would just.
It's really good, and I don't want to miss any essence of it because it was really very good.
This was going to be a relaxing hour and a half for me. Just a reality check on that score. As my boss has mentioned to me weekly, there are no new dollars. And we've already started the next biennium's budget process. And, I used to work here. And if Troy Streckenbach, my previous boss, the county executive of Brown County, were here, he'd be reminding me there's not going to be any new property tax dollars coming. That's the challenge we have. And those are realities.
About that lean idea that we talked about.
Well, I did want to make a comment about that, and I wanted to make a comment about training too. I think Todd, you alluded to this. Part of the solution, if there is a partial solution that we can look at, it would be in the area of training, and particularly in behavioral health training. And we have plans that are well underway for that, and it's a certificate program, and we found a way to cover the cost of that, and we want to expand that to direct caregivers. And that's going to be through UW Oshkosh. We're looking at an online design. We're looking at an initial investment with a very low maintenance fee thereafter. So there are some things that I think we can do business together when it comes to training, to the extent that there are other ways to give recognition, to give a greater sense of professionalism and that sort of thing. I think we can work down that alleyway. Lean. When I came to Brown County, I'd had experience in a large healthcare system, ministry healthcare. It was my exposure to process improvement, quality improvement methodology, CQI, all of that good stuff. And when I came to Brown County, fast forward, I found out that they were employing some of that similar methodology, lean to be specific, and they had several lean facilitators, trainers available. I knew what I faced with my agency in Brown County and some of the demands that were going to be placed on it. And I said, I'll take all the lean capability and time that you can give me. The first year we outstripped it. Our demand outstripped it. So the second year, I decided that we needed to gear up and get some people trained in lean methodology. We did that. We faced cutbacks in county levy to support our programs to the tune of about $2.5 million to $3 million over the course of several years. Precious levy funding, as we called it. And if it were not for the lean methodology that we employed, we would not have been able to either maintain the services that we did, but we were able to actually expand in several areas. The lean methodology is basically, and I want to say this real quickly, for those of you who are familiar with it, you can tune me out. For those of you who are not familiar with it, it's not taking meat axes and cutting programs. Rather, it's finding ways, chasing out waste that you have built in to your programs. It's not about firing people. It's not about laying off people. In fact, line workers are key to employing lean methodology. You have to involve, it cannot come from top down from management. All management can do is to say, we're committing to this process. But if management tries to find the solutions, we will fail. It really requires working with your line staff. That's where the answers are. It's a matter of mobilizing them and ferreting out waste, finding new efficiencies within your program. And in fact, in our division, we're heading down that lean path already. And hopefully, I would like to be able to assist in providing some training to embed it not only in our MCOs eventually, but eventually in their provider networks. So I'm very interested in that, and I want to thank you again, Thomas, for reminding me of some of the other conversations we've had about this. Thank you.
My comment is for Todd. I think your entire presentation spoke volumes to me. As a consumer of long-term care for now almost 27 years, my entire life, but now living on my own for the last almost 8 years, caregivers and quality caregivers are an integral part of me living on my own. And you spoke volumes to keeping caregivers and having well-trained caregivers. And my experience, as well as my caregiver sitting next to me, as we were all both saying the entire time you were speaking, is that it's difficult to keep caregivers because their turnover rate is so incredibly high, as you spoke about. But we find, and I find, that I often train my own caregivers. The agencies say that they're trained, but they come in and because they're hired, and they come in and they often have no idea what they're doing. Their lack of training and experience becomes a huge issue. So I often find myself training my own staff about my needs and my specific needs. There's a lack of quality training, I find, across the board, and I think the general public's view is, well, just go find yourself some caregivers. That's not as easy as it sounds, and for myself, I don't have a whole lot of family support, actually none. So I rely on agencies and, companies to pay caregivers, and pay is an issue. They're making peanuts for doing what's supposed to be quality care, and I'm relying on them to show up on time and do their job, and I can't pay them any more than what they're making, so I have to hope that they're doing a good job. And as a social worker myself, I know the reality out in the world, and it's just a tough situation to be in, and you're saying all the right things. So I commend your presentation and everything you're saying, because what you're saying is the reality.
That was a great way to end this forum, bringing it right back to somebody who is using the services and the concerns around them. So thank you very much for making that comment. We do have lunch is being served buffet style. You can bring your lunch back in here. When we've kind of settled down from eating, then we will have Representative Richards and District Attorney Ozan speak to us. Thank you. Ozan, on August 1st, 2010, Ismail was appointed to be the Dane County District Attorney by Governor Doyle when the District Attorney at the time, Blanchard, was elected as a Court of Appeals judge. Mr. Ozan is the first African-American district attorney in Wisconsin's history. Prior to becoming Dane County's DA, Ismail served as the executive assistant for the Department of Corrections. He worked on the Department of Corrections budget, the Department of Corrections response to racial disparities, and Act 28 sentencing reforms. And in July 2009, Governor Doyle appointed Mr. Ozan to become the Deputy Secretary of the Department of Corrections, where he was in charge of daily operations. He received his Juris Doctorate from the University of Wisconsin-Madison Law School in 1998. While in law school, he interned with the Legal Assistance for Institutionalized Persons at the Oxford Federal Prison, the Appellate Project, which was the start of the Innocent Project of today, and the Prosecution Project, which placed him in the Dane County District Attorney's Office originally. Please welcome both candidates for Attorney General, and I'm going to go ahead and turn it over to Mr. Richards first.
Well, thank you, Tom. It's great to be with you here today, and I wanted to thank you personally also from behalf of my family. I have an aunt who is in her late 50s who has some significant disabilities and works in a community rehabilitation program in Waupaca County. And it's through her eyes that I see the vitally important work that you do around Wisconsin. And it's a difficult working environment with people with some real challenges, often not paid very well, and where you aren't reimbursed by the state very well for the work that you do. As was mentioned, I'm currently a member of the legislature. I'm a member of the Joint Finance Committee also, and so we were very actively involved with several of the discussions this year about expanding family care to Northeast Wisconsin. I'm glad that finally happened. It shouldn't have been so long of a fight, but I'm glad it finally happened. Also was very active in trying to make sure that we expand Badger Care to people in Wisconsin and to take the federal expansion money afforded under the Affordable Care Act. I think it was a real shame that Wisconsin did not take that. It was a real lost opportunity that would have saved us literally hundreds of millions of dollars in our state budget, but much more importantly would have covered tens of thousands of Wisconsinites who really need the help. Some of them might be your clients, some might be your friends and neighbors. But that's something that we really should have done. And those are kind of examples of the values that drive me in public life, and one of the reasons why I'm running for Attorney General. I'm running for Attorney General because I think we need to have someone with some strength and experience in that office who can protect Wisconsin's families and also stand up for our values at a very difficult time in Wisconsin's history. To protect our families, first and foremost, we need to deal with problems of public safety and keeping our neighborhoods safe. And one of the things that we need to do a much better job of is working closely with our local law enforcement officers and local district attorneys to make sure that they have the resources they need to get their job done. I've been a leader in that fight in the legislature, and that's why the Association of State Prosecutors gave me their top award last year. I've also been able to work with Democrats and Republicans to get tougher on drunk driving, to make sure that we're protecting domestic abuse victims, and to address the scourge of heroin that's infecting every county in this state. And that's certainly work that we're going to be doing with the Attorney General's Office on public safety. But the Office of Attorney General is also about protecting our families in terms of our communities, our pocketbooks, and our freedoms. And let me talk about some of those things with particular focus on the work that you do every day, because it's challenging work that needs to be addressed. First of all, I think when we're talking about people, seniors or people with disabilities, the overriding value needs to be that they need to live as independently as possible and as dignified of life as possible. And I see that value through my aunt's eyes, but also in my work as a guardian ad litem from Milwaukee County, where I work and review people who are disabled and go into their settings every year to determine whether they need a guardianship or protective placement or if they need that continued. And you certainly get an up-close and personal view on what goes on in people's lives. And sometimes it's pretty obvious that a person is in need of that kind of protection, but sometimes it's a close call. And you see in your lives that there are some times where you might have a situation where a person is in a situation where they're not living as independently as they could be. And I think at that point, it's in everybody's interest, and certainly it's in that person's rights to live as independently as possible, and to have the courts and the justice system move towards that end, to make sure that they can live as independently and freely as they can. I've also been watching very closely this issue with voting rights, and as you may have seen yesterday, we had a very important decision come down from the federal courts in the Eastern District of Wisconsin that invalidated the law requiring a photo ID in Wisconsin. And one of the things that happened with that decision was a very careful analysis of how that would impact people in Wisconsin. And the judge in that case took quite a bit of testimony about who would be impacted by that case and that law. He found that there were about 300,000 people that would be impacted, that would either not be able to get a valid state ID under any circumstances, or would have to essentially pay the state to get the information that they need for that ID. I don't think that's right, and I don't think that that's in keeping with Wisconsin's long tradition of expanding the franchise to vote, and one of the reasons why we have such high voter turnout in our state is that we have placed a high premium on allowing people access to the voting booth, and the state has been on the side of people who want to get access to the right to vote. Up until recently, that is. And I think we need to return to that idea, and under my watch, the Department of Justice is going to be working very closely with people who are trying to exercise their right to vote, so that every eligible citizen who's able to vote, who is eligible to vote, is able to vote. Another issue that's come up that I want to make sure that we talk about today, if we have time, that just came up last week, is the issue of non-emergency medical transportation. And we have a new vendor in our state that is really, I think, causing some serious problems. We heard stories last week from testimony of people who have to go from here in Green Bay down to Frederick Hospital in Milwaukee. They go in for a test or a treatment, and their transport doesn't show up, sometimes for an hour or 2 hours, sometimes for half a day. So you have a person who is very uncomfortable after a procedure sitting at Frederick Hospital and no one's coming to pick him up. That is completely unacceptable. And I'm glad that we're undergoing a extensive audit of the company that holds the contract to make that transportation available. But I think that's the sort of thing that the state should be taking a very close look at. In my role as a legislator, I work closely with people who are in nursing home and in institutionalized settings. And 2 years ago, I worked with many of you and AARP to draft the Senior Citizen Protection Act to make sure that people who are injured in nursing homes can get recourse for the injuries that they have. I think that's an important step that we have to take. Unfortunately, one of the things the legislature did a couple of years ago was to remove the protections that people have in nursing homes and to remove any recourse that they have if things go haywire in a nursing home and they get hurt, or if they're misled in a contract in a nursing home. I heard testimony from people who go into a nursing home setting sometimes and they arrive and they are presented with a stack of documents literally 3 inches thick at a time where they're going through some of the most stressful moments in their life, and they're expected to wade through these documents and make all these decisions, and it's just completely unreasonable. So what we're trying to do is provide some reasonableness into the standard of admissions into nursing homes and make sure people can understand what they're signing when they go into a nursing home. So those are types of things that we're talking about in terms of issues that might be of particular interest to your work. But I also want to talk in general about some of the issues that we face here in Wisconsin. And as your Attorney General, I'm going to make sure that we stand up for rights in the workplace, as I have through my entire public career, and I have a 100% lifetime labor voting record with the AFL-CIO, and I think it's important to make sure that we advance rights in the workplace. I think it's important that we stand up for a woman's right to choose, and I think that's a constitutional right that we need to advance, and that's something that I will certainly do as your Attorney General. I think we need to make sure that people are paid fairly, and we still have an issue of women getting paid less than men for the same work, and as your Attorney General, I'll make sure that people are paid fairly in the workplace. There's a lot of work to do in Wisconsin, but one of the great things about living here is that we have a long tradition of doing right by our citizens, and we've had a long bipartisan tradition of doing that too. You know, there was a time when Democrats and Republicans could work together on a whole range of issues, from expanding voting rights to open housing laws, even working together to ban discrimination based on sexual orientation. It's not just happy talk to say that Democrats and Republicans were able to work together at one time. That really did happen here. And I think we need to return to that. And that's something that I am absolutely committed to doing as your Attorney General. And I look forward to working with you to build a Wisconsin that is as great and as fair and as decent as our people. And I look forward to having any questions you have today. Thank you very much.
Hello, I'm Ishmael Ozan, Dane County District Attorney and candidate for Attorney General. And I want to be your next Attorney General. And I'll get into why in just a minute. It was nice to get here a little early today and to hear some of the speakers and some of the questions and some of the issues that you are dealing with. When I think about my personal experience with these issues, and looking at me, maybe you won't think that I have some of those, but my grandfather died when he was 92, a few years ago, actually a number. But we were lucky because of the 4 sons that he had, my father being the oldest, the youngest was a doctor. And he went into holistic medicine, and his practice is not such that tied him down, and he was able to give care to my grandfather. Which, when I look at it, was huge for our family. My grandmother, who's in her 90s, still lives just outside of Two Rivers, or Trivers if you're from there. And that's where they retired to. And I currently, in Madison, live in the home that they built in 1951. So I have the 4th generation of Ozans growing up in that home. But my uncle, the doctor, is now able to be with my grandmother. Now, she is mobile. She takes walks every day. She's quick as a whip. And she notices that, her memory is slipping a bit. And that frustrates her because she can understand when she may have asked you a question and that she's asking it again. So these are issues that we are all dealing with. Myself, obviously, I'm the only son of 2 parents who at some point may need care. And I'm a father of a 6-year-old and a 4-year-old who will probably never be able to stop working so that I can get them through college. So yes, I understand sort of the issues that we are all facing. I also understand the difficulty it is to find good help. Not that people don't care, not that people don't want to help, but people that are trained and have the ability to do the work, because it is demanding. It is very demanding, especially if you on your own are trying to get somebody out of bed and into a chair, or from a chair into the bed, or just adjusted within a bed. I do have a friend who is my same age who now actually has gone into the service industry. So he, in Dane County, has a comfort care business, and he has about 160 employees, he tells me. About 115 clients. They have about 20% turnover, and the client base is growing. And it's growing because the cost of hospitalization and other fees, and the reality that people just want to stay in their home is causing the need. So we see this going forward. And for us to stand here and say, well, we're going to have a train wreck because there isn't enough money, because there isn't enough people out there to take these jobs, because we have these difficulties, is unacceptable for Wisconsinites. And I say that because when I travel all over this state, what I'm finding is we are more alike than we are different. We all have these same issues. We are hardworking, practical people. And we need to say, now we see the problem, where is the solution? Now, I'm also the Dane County District Attorney, and I've been a frontline prosecutor for going on 14 years now. And I've tried hundreds of cases, from first-time drunk driving to first-degree intentional homicide and everything in between. And I've also run the day-to-day operations of our state's largest agency, the Department of Corrections. So basically, I've spent my entire career working to keep our community safe. What I see from that lens as well is added stressors on families. And when you have added stressors on families, especially if what we have is more reliance on the family to try and meet the need because, one, they don't have enough resources to bring someone in. Two, they probably are working two jobs as it is. The difficulty in giving care is going to increase. Even though my grandpa had all of his mind working, he had a series of small strokes which caused him to have a difficulty speaking and swallowing. And, you know, one aside, it was sort of interesting. After he passed, my uncle said, you know, Grandpa had a living will. And that living will said, no extreme measures, no feeding tubes, you know, and sort of we looked and he had oxygen at the end and a feeding tube, and at no point would he have said, don't give that to me. But if you looked at the letter and said, okay, well, should you have just let him be? And I know that he wouldn't have not asked for those things, because one of the most difficult things for him when he stopped being able to swallow hard foods was everyone else around him eating. And even though he was getting the same dinner that everyone else had, he got it through the tube. And he said at one point, he was just so frustrated, and he was like, you're taking all the fun out of it. But that was frustrating for him. And that frustration at times caused him to lash out at people that he loved. Not at the caregivers, but at the people that he loved the most. And that is an added stressor on family. So from the district attorney's side, what I see and what we have seen is a rise in abuse and neglect. And it is especially difficult when we are talking about our most vulnerable populations. Now, we are dealing with, in Dane County, dealing with child abuse and neglect. And we have a program that we've started to help parents who have used excessive physical discipline. And I shouldn't complain because it got me above the fold on the front page. And the experts in the field actually said that this works. Even though the other candidates in this race took political shots, maybe not knowing about evidence-based practices, maybe not knowing that it's never okay to abuse children, and that if we don't change behavior, we have not made children safer. That said, when we have these added stressors, we are going to see added problems in the criminal justice system. And we have to look to keep people safe. We have to figure out how best to do that for our most vulnerable at the youngest and our most vulnerable in the more senior times of life. Because one of the things that I saw also, I cut my teeth on domestic violence cases. I prosecuted domestic violence for about 8 years before I went into a felony drug caseload and then on to corrections, where I was executive assistant, then deputy secretary, and now back to district attorney. And what you saw in the domestic area, which I think is exacerbated when you were dealing with a victim who is older, they want to stay in their homes. We want them to have the dignity, and we want them to be able to have things around them that give them comfort, that keep them active and engaged, because that's what keeps us healthy. But they get into a situation where that caregiver may be the person victimizing them. But we as the criminal justice system have to also understand that if you take that caregiver out because you are now going to charge that person, what have you done to that person who needs the care? So if law enforcement comes in and says, we believe a crime's happened, we're going to take you to jail, we have got to be thinking, what time of year is it? What needs does this person have? Because that person, if you just walk away and close the door, you may have locked that person in. You may have caused that person to have a real risk to their life. These are issues that the criminal justice system has to deal with. These are issues that we all should be looking at and trying to combat. And a big part of that is what you're struggling with here and now. Now, why is the Attorney General's candidate here talking to you in this manner? Because most people think of the Attorney General as the top cop. And we're talking about being tough on crime and the like. I think that is true. I think public safety is job number one. And I think that you need, and we need, an Attorney General who is going to make sure that law enforcement and the communities have the resources and training they need to keep us safe. But at the same time, the Attorney General has to do more. And the beauty of our Attorney General is that it's not tucked under the executive, like the federal system. The Attorney General in Wisconsin is standalone and answers only to the citizens of the state of Wisconsin, which means the Attorney General has to look to protect all the rights of the citizens of the state of Wisconsin. And that protection may take on different forms. If we are talking about a child predator, that form may be, listen, that person just needs to go to prison. Simple. We prove it, we get them off the street, we separate them from the community. If that person is a parent who loves a child and we can change that behavior, maybe we have actually made ourselves safer by strengthening that family, by changing parenting behavior to protect that child and other children in the home. If the risk is to a more senior person or a person with dementia, how can we keep them safe with dignity, as well as dealing with cost, which is what the state is going to talk about and what local governments are going to talk about. One area that I will tell you there's a lot of resources put is corrections. Corrections eats up a lot of resources. Because when we decide to separate someone from the community, we take on their care. And when I left corrections in 2010 in August, so halfway through the year, a little more, then the person, one inmate, had cost us $500,000 within that year. And you'll hear that inmates cost $30,000 to house for a year. And I will tell you that that is if the person is healthy, has no mental health issues, no dual diagnosis issues, and many of the people who come into the institution have not had health care prior. So they have not had the benefit of preventative care. So when they come into the system, you have to deal with that. If one of our inmates that we have the responsibility for needs a transplant. They receive a transplant. They receive some of the best medical care in the world. They're taken down to UW Hospital, and we take care of that because we have assumed the care. Now, because we are keeping people in our institutions longer and longer, the same issues that you are struggling with here at times with aging and disabilities, we find there. But in those situations, we also have individuals who the state is now paying 100% of that care for. Some of those individuals may not pose a risk to the community as they once did. Some individuals may not be able to walk from me to the door before this room could empty, without having to take a seat before they got halfway. We should be talking about ways to manage that care of those individuals that would still keep us safe, but save us a lot of dollars. And those dollars could be put back into the system either here, education. We could also be bringing, instead of using all state funds, federal resources down. So I bring these issues up because these are issues that we all face. And if we don't face them here and solve them here, at your level with your prosecutor, at your level with your attorney general, we will have to deal with situations where we are looking to prosecute people. And we know we have a system at this point that is somewhat broken. We are finding out that Wisconsin is the best for being the worst for racial disparities, for opportunities for achievement for persons, children of color. In Dane County, the Race to Equity showed that although we are always in the top 10 of places to live in the country, unemployment is relatively low, considering that more than 75% of the children of color live under the poverty line, versus 5% of Caucasian children. I say this because we as Wisconsinites are more alike than we are different. And we want a level playing field. We don't want one road for money and power and one road for the rest of us. And by us coming together like we are, solving the problems that we can see, we actually will make ourselves safer. We actually will make our opportunities greater. Because if we allow a child to grow up without empathy, we are creating our own worst nightmare when that child becomes an adult. So, the Attorney General must do more than just public safety. One of the accomplishments that we have to applaud our legislature for is the Silver Alert. That happened this session. I found out about it. I started talking about it. I'm not claiming any credit for it because I cannot. But we need to be bringing awareness to these issues. And I tried to do that prior to the vote. And I'm glad that they actually took the vote. Because as I see it, this legislature took its time, not working on public safety, not working on jobs, but working on decreasing access to the polls, and making it easier for special interests to pollute and take our natural resources. Made it harder for local communities to protect their resources and have a say in how those communities will move forward with development as well as protecting our natural resources. I toured the Pinocchis on Earth Day, met with the Lakota Ray and saw their school where they are actually doing dual language immersion in Ojibwa, in their native tongue. It was an absolutely amazing thing to see. And then they toured me through the Pinocchis, and I couldn't really wrap my mind around what was being proposed until I sort of was able to actually see it with my own eyes. And we were proposing in that area of the state a 1.5-mile gash 1,000 feet deep, stretching from the east side of Madison to Johnson's Creek. That's the gash that they want to put on top of a watershed that feeds into the largest fresh body of water on this planet. And then give a 20-year pass for pollution. These are things that speak to the core of who we are as Wisconsinites. No matter whether you're in rural Wisconsin or urban Wisconsin. Now, some know me for my challenge to Act 10. And actually, it was addressing the open meetings law violation. And I will say that that's the biggest difference between our current Attorney General and myself. He could have addressed the open meetings law violation, but chose not to. And I didn't blink. I took our challenge straight to the Supreme Court. It was not a partisan challenge. It was a challenge that spoke to open government. It was a challenge that looked to protect our access to our own government. It was about making sure those who write the laws are also accountable to those laws. And I believe we have to stand up and fight for open government every single day. And when you look at the aftermath of what happened, what that 4-3 vote on the Supreme Court did was it threw out 30 years of open government the state had become accustomed to. And the worst thing it did was it turned Wisconsinites against Wisconsinites. We are better than that. We solve problems, and we move ourselves forward. Just like our motto says, forward. I want to be your next Attorney General because I want to stand up for you, the citizens of the state of Wisconsin. I want to ensure that we have no second-class citizens in this state. I am not afraid of a fight on the behalf of the citizens of the state of Wisconsin. And I believe at this time I am the only candidate in this race, Democrat or Republican, who is firmly planted as being a frontline prosecutor, which I believe the citizens of the state expect and deserve their Attorney General to be, with a proven track record of standing up for the citizens of the state of Wisconsin and protecting our shared values. Now, there's been some talk about electability, and I typically don't go into this, but I think I should. Because, and that's fine. That's perfect timing. And I will say this. Some have said, how can you be elected? You come from Dane County. And I've just sort of scratched my head and thought, well, looking at history, Jim Doyle, Tammy Baldwin, Russ Feingold, Fighting Bob LaFollette, they've come from Dane County. Peg Lautenschlager did not. She came from Fond du Lac, but she's endorsed me in this race, so I think that's a good thing too. One thing I do want to leave you with is this. I may come from Dane County, but I'm a sixth-generation Wisconsinite. We can trace those ancestors back to 1842. My grandparents came from Neenah, and as you've heard, my grandma still lives just outside of Two Rivers or Trivers. My grandfather taught high school in Wisconsin and high school in Colorado. And in Colorado, he organized the Colorado Teachers Union. On his way back, he helped organize the Retail Clerks Union, and when he got back here, he headed the School for Workers at the UW-Madison and wrote books on Wisconsin labor history, which I believe if they had been read by some, we would not be in the position we are today. My father was a teacher, taught at Tuskegee University and high school in Madison for a time, and my mother is still a teacher today, teaching reading at James C. Wright Middle School. Although she says she's going to retire, so hopefully she'll spend more time with her granddaughters, teaching them. But she was also one of the first women welders at Kuffer Iron Works in Madison. So she was an iron worker. And she marched for civil rights in the 60s, which is especially poignant today because of the attack on access to the polls. When she was 17, she joined SNCC. She was in Mississippi for the Freedom Summer, registering people to vote, searching for those civil rights workers who went down and lost their life on the first day of Freedom Summer. She knew she was risking her life but she knew something had to change. She knew there had to be a change, and she didn't know how she was going to be part of that, but she knew she would be. And then when she came here to UW-Madison, into Wisconsin, she then went back into the South with other students and helped collect the enormous civil rights documentation and memorabilia that we currently have in our State Historical Society today, which is incredibly poignant to me because people gave their lives, people risked their lives, people suffered beatings, all for the ability for someone else to vote. Yet today, it's almost as if we have to pull teeth to get people to the polls. And it's as if we are not taking notice of who is going to be impacted when we close access to the polls. So I will always fight to open access to government, to the polls, to protect the rights of the citizens of the state of Wisconsin. And that's what I wish to bring to the Attorney General's office and why I want to be your next Attorney General. I need your support. I need your vote. August 12th. Thank you.
Thank you all for attending, and I hope you all think this was as good and valuable as I did.